today from India and across the world. I am Ashish Shah from Intas Pharmaceuticals Limited. I, on behalf of Mumbai Hematology Group and Intas, welcome you all to today's academic feast of not just one session but two interesting sessions. We are indebted to Professor Dr. M.B. Agarwal sir for starting the longest running webinar series in hematology or perhaps any specialty in the world. This webinar series, which we are witnessing today, has completed proudly 5 years and it is still counting. So we are really thankful to Professor Dr. M.B. Agarwal sir for assisting us with the education every weekend. Dr. Amit Khurana needs no introduction. The passion with which Dr. Amit Khurana drives these academic webinars is uncomparable. And we hats off to Dr. Amit Khurana for taking charge, a very important responsibility of Mumbai Hematology Group, which is really appreciated by everyone, not just in India but across the world. Without we taking much of the time, would request Dr. Amit Khurana sir to take the proceedings forward.
Yeah, thank you, Mr. Ashish. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today we have got two guest speakers. Our first guest speaker is no other than Dr. Hani Al-Samkari from Boston, Massachusetts, USA. And our second guest speaker is Dr. Rajshekhar Chakraborty from Columbia, USA. To introduce our first guest speaker, we have with us Dr. Hani Al-Samkari from Boston, Massachusetts, USA. And he'll be lecturing us on immune thrombocytopenia from thrombopoietin receptor agonist to novel therapies. Our second guest speaker is Dr. Rajshekhar Chakraborty from Columbia, and he is going to lecture us on smoldering multiple myeloma. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Intas, and very well managed by Perfect Square. I thank Mr. Arun Hegde, Dr. Manoj Kumar and the team Intas, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speakers for the day, Dr. Hani Al-Samkari from USA and Dr. Rajshekhar Chakraborty from Columbia, all our discussants who are themselves very eminent hematologists as well as medical oncologists, and you participants for sparing your Saturday evening, morning or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 25th May 2025 from 11:30 a.m. Indian Standard Time, we have Dr. Gaurav Prakash from PJ Chandigarh speaking to us on precision medicine in lymphomas as I practice in India. Let me introduce our discussions for the day, and they are displayed here in alphabetical order. I stop for a while for you to have a look on all our discussions for the day. So these are our discussions for the day. To introduce our first speaker, we have with us Dr. Hani Al-Samkari from Boston, Massachusetts, USA. Dr. Hani Al-Samkari is the Peggy S. Blitz Endowed Chair in Hematology Oncology at Massachusetts General Hospital and an Associate Professor of Medicine at Harvard Medical School. He is a classical hematologist and NIH-funded clinical investigator and clinical trialist. He also serves as co-director the MGH Hereditary Hemorrhagic Telangiectasia, that is HHT, Center of Excellence. His clinical and research interests are in hemostasis, thrombosis, and hemolysis, with focuses on HHT, immune thrombocytopenia, and hemolytic anemias. As a clinical investigator, he is an internationally recognized expert in the clinical development of novel therapeutics for these disorders and serves as the lead principal investigator for multiple ongoing clinical trials. He is a current executive editor of Hematology, the ASH Education Program, an American Society of Hematology peer-reviewed publication, and has published over 150 peer-reviewed manuscripts. His original research has been featured in the New England Journal of Medicine, The Lancet, Annals of Internal Medicine, and Blood, among other top peer-reviewed journals in hematology and medicine. Today, he's with us and he's going to lecture us on immune thrombocytopenia from thrombopoietin receptor agonist to novel therapies. Well, I stop over here. Over to you, Dr. Hani Al-Samkari.
Wonderful. So I'll go ahead and share my screen. First of all, Dr. Karan, I just want to thank you for that very kind introduction. I'm going to thank Mumbai Hematology Group and Dr. Agarwal for this very kind invitation to speak to your group and interact with all of the eminent discussants and to have the opportunity to talk about a topic that's, I think, very interesting and near and dear to my heart, which is ITP. Just want to confirm everyone can see my screen, my PowerPoint slides.
Yes, perfect. Please go ahead.
Excellent. All right. So lots to talk about in ITP. ITP is a disease that has been evolving over the last several decades and continues to evolve. And we'll take, this talk is really a journey through a little bit of the past in ITP, most of the present in ITP, and then the future in ITP. All right. So here are my disclosures. So we're going to start with current state of ITP and perhaps just a touch of past, talk about the evolving landscape of thrombopoietin receptor agonists in ITP, which are in many cases are workhorse drugs in ITP, but then talk about all the emerging targeted therapies in ITP. So no discussion of ITP would be complete without mention of the Harrington-Hollingsworth experiment. So Bill Harrington in the 50s was a fellow, a hematology fellow at Barnes Hospital at Washington University in St. Louis, and he famously infused himself with half a liter of blood from an ITP patient, whole blood, all right? It's called the Harrington-Hollingsworth experiment because his co-fellow was a gentleman named Hollingsworth who was spared from the infusion because his ABO blood type was different than the patient's and Harrington's was the same. That was the reason why Harrington got it and Hollingsworth didn't. Of course, what followed was a precipitous drop in Harrington's platelet count. He had a major grand mal seizure, and then had multiple bone marrow biopsies because, again, at this time, they had no idea what caused ITP, and the impetus for this experiment was because Harrington and Hollingsworth thought that it was due to a circulating factor in the blood, which of course it was, and it was later determined to be IgG platelet autoantibodies. And we have here a figure from that famous experiment with more than one line on it showing the drop in healthy volunteers' platelet counts after receiving plasma from a patient with ITP. So Harrington was the guinea pig. He got the whole blood. And then the rest of the Washington University Hematology Division was volunteered to receive plasma from ITP patients. And we see that their platelet counts dropped in response to those platelet autoantibodies, and then they recovered. Now, we've come a long way in understanding ITP pathophysiology. We recognize that this, of course, is an autoimmune disease. A loss of immune tolerance leads to recruitment of CD4 positive T cells and activation of B cells that produce platelet autoantibodies. Platelet autoantibodies destroy platelets in the periphery, and they bind to megakaryocytes in the bone marrow, resulting in premature apoptosis of megakaryocytes. There is destruction of platelets via multiple different mechanisms from platelet autoantibodies, which include direct antibody-mediated destruction and phagocytosis, as well as complement activation, complement fixation, and destruction of platelets via complement-mediated mechanisms, but also T cell-mediated immunity. So T cells are now well recognized in addition to the humoral and complement aspects of ITP as being a very important aspect of the ITP pathophysiology. And CD8 positive T cells, cytotoxic T cells, destroy platelets and they directly destroy megakaryocytes. So ITP is both a disease of increased platelet destruction and inadequate platelet production. If you look at the rate of platelet production in an ITP patient, and Dr. Terry Gernsheimer did this and published in the New England Journal of Medicine in the 80s, The rate of platelet production in patients with ITP is actually higher than healthy subjects. It's just not adequate to cover the degree of destruction and turnover. All right, so let's go through some cases to wrap up all of the information that we're going to be talking about to I suppose contextualize the information we're going to be talking about. So a 66-year-old woman with a past medical history of hypertension and Sjogren's syndrome presents to the ED with diffuse petechiae of the upper and lower extremities. She awoke this morning to the taste of iron in her mouth and saw large blood blisters in her oral mucosae. On initial labs, her platelet count is 4,000. The remainder of her CBC is unremarkable. She endorses recovering from a case of bronchitis about 3 weeks ago. She states that she felt relatively normal about a week ago, but has had worsening fatigue for the past 3 days. Patient is admitted for treatment of newly diagnosed ITP. This is a classic case of newly diagnosed ITP. When told she is to receive treatment including corticosteroids, she becomes anxious as she states a prior 3-day methylprednisolone pulse given for a complication of her Sjogren's made her anxious and jittery. How would you treat this patient? So we could give prednisone 1 mg per kg over a 6-week taper. We could give dexamethasone 40 milligrams times 4 days for 2 to 3 every other week cycles, dex pulses. We give IVIG. We could give prednisone plus IVIG. We could give dexamethasone plus IVIG. All right, so there are multiple correct answers here, potentially correct answers. Let's talk about it. So corticosteroids and ITP, we primarily use dexamethasone and prednisone or prednisolone as our 2 major options. Occasionally, we'll also use methylprednisolone in patients admitted to the hospital. There's been a lot of back and forth about, is one choice better? Is it better to use dexamethasone pulses because of the potential lympholytic effect of just a very high dose of a very potent corticosteroid? And it turns out that really has not panned out. There is no superiority of dexamethasone over prednisone. Really, what you're getting with dex is potentially about 24 hours sooner of a response, which is great. But the trade-off there is you may have more. You generally do have a higher risk of acute steroid toxicities, like in particular, if in this 66-year-old woman, right, who has had anxiety and jitteriness, psychiatric, side effects of steroids, which can lead to full-blown psychosis in elderly patients, a little bit more likely in dexamethasone than the lower dose prednisone. So that's something just to keep in mind, but both are relatively equal, as has been shown in this meta-analysis from Mithuani and colleagues that was published in Lancet Hematology just a few years ago. There really is no difference in the overall response rate at 6 months. IVIG, of course, has a good response rate in newly diagnosed ITP, about 80% or even a bit higher than this, and works faster than steroids, is his main claim to fame. Faster, but not quite fast, I would say, right? Particularly for patients that are presenting with acute internal hemorrhage. It still takes about 24 to 48 hours for dexamethasone, or excuse me, for IVIG to work in optimal cases. But when patients are acutely bleeding, they can receive dexamethasone and they can receive steroids and they can receive platelet transfusion all at the same time to try to minimize that bleeding. Toxicity, of course, of IVIG, we must not forget headache, which in extreme cases can be an aseptic meningitis picture, venous thromboembolism, potential anaphylactoid reactions in patients with IgA deficiency who need to receive IgA-depleted IVIG. So, this is not a benign, treatment, which is why we don't give it to everybody. We just give it to those patients that really need their platelet counts to be up faster because they're acutely bleeding in a clinically relevant fashion, or they're at high risk for that. All right, so case 2. A 30-year-old man with chronic ITP presents for follow-up. He's not currently receiving therapy, though received dexamethasone treatment 18 months ago when he was diagnosed. He denies bleeding or constitutional symptoms at this time. His platelet count today is 29,000. The remainder of his CBC is unremarkable. He is not on antithrombotic therapy and lives a sedentary lifestyle, working an office job. He does express anxiety about his platelet count, as it was 45,000, or he says 50% higher, at his prior visit 3 months ago. So how would we manage this patient? We hit him with dexamethasone pulses, start avatrombopag, a thrombopoietin receptor agonist, initiate rimiplostim, another thrombopoietin receptor agonist, refer for splenectomy, or observation reassurance. So, the treatment approach and goals in ITP, right? We have to balance improvement of the platelet count and being happy with the numbers with the toxicity of therapies and the cost of therapies. And we also want to manage patient anxiety. This gentleman has some anxiety, but he's not bleeding. He doesn't have comorbidities that predispose him to bleeding. He, is a sedentary gentleman. He's not, actively participating in sports or things that could increase his bleeding risk. So, it's reasonable in this case, even though his platelet count is 29,000, and sometimes we say we want a threshold of 30,000 for observation. The ASH guidelines use a threshold of 30,000, 29,000, and 30,000 are the same number. We can be reasonable. He does well with observation and reassurance for the next 2 years, with platelet counts fluctuating in the 25 to 50,000 range without therapy. At this time, though, he calls the office because he noticed some new, if minor, petechiae on his legs. He got over a bad head cold 2 weeks ago. He's found to have a platelet count of 15,000. Okay, so now it's reasonable to treat him. He's bleeding. His platelet count is less than 20. So options: admit and begin 6-week prednisone taper, initiate avatrombopag, initiate rimiplostim, refer for splenectomy, initiate rituximab. Right. So again, multiple correct answers just to illustrate a point and illustrate our options. The answer here that I would really try to avoid would be A. It's always tempting to give these patients corticosteroids. He's got some minor petechiae. We've known this patient who now has chronic ITP for a number of years. It would be reasonable and appropriate to avoid steroids in this guy and give him something else to raise his platelet count, or at a minimum, use minimal steroids. You don't have to give it for 6 weeks. You can give it for a week or two while a thrombopoietin receptor agonist is working. And certainly, at least, in the US, we would not feel a need to admit this patient for a chronic ITP and a platelet count of 15,000 with minimal bleeding. So the American Society of Hematology guidelines were most recently updated in 2019 for ITP. And, this is, I think, a very unnecessarily complicated figure. I put it on here, not because I'm going to go through it, but because this is a lot of boxes to basically say, treat patients, talk to patients, figure out what their lifestyle is and what their treatment goals are and what they would like to avoid, and select therapies for second-line ITP on that basis. Now, the motivation for this is that we don't have randomized controlled trials comparing thrombopoietin receptor agonists to rituximab or rituximab to splenectomy. We don't have randomized controlled trials comparing second-line therapies. We have randomized controlled trials comparing second-line therapies to placebo. So we know we don't want to use a placebo. If the patient is at ITP for less than a year, then we try to avoid splenectomy because splenectomy has, you can't reverse a splenectomy. It has long-term consequences in terms of thromboembolic risk, which remains for the remainder of the patient's life, in terms of life-threatening sepsis, which remains for the patient's life. It obviously doesn't work in every patient. And in the first year, there is a real spontaneous remission rate that we want to give the patients an opportunity to have, which is why we don't splenectomize in the first year. But if they're chronic ITP, if they've had ITP for longer than a year, then consider rituximab, consider thrombopoietin receptor agonist, consider splenectomy, and if available, can also consider a spleen tyrosine kinase inhibitor like fostamatinib. So splenectomy, oftentimes people will quote, there's a 2/3 chance that if you get your splenectomy, if you get a splenectomy, it'll cure your ITP. And this was true in the pre-rituximab and the pre-thrombopoietin receptor agonist era, when splenectomy was used after failure of corticosteroids and IVIG. Now we know that, first of all, the rate of splenectomies have been going down as we have drug options to treat this disease that are well studied and approved. And if you look at the modern era, Splenectomy success rate is not 70%. It's actually in patients that have failed both rituximab and one thrombopoietin receptor agonist, their success rate for splenectomy is less than 50%. It's about 46% in a recent study published by the French group evaluating a large number of splenectomies. Not so many that had failed both rituximab and a TPO-RA, but nevertheless, this is the data that we have. So, for most patients, the success rate here is really about 50-50 or even a little bit worse because most patients don't get a splenectomy until they've tried and failed other therapies. And we're selecting out for more severe, more refractory patients. So predictors of non-response for splenectomy, age greater than 75 and 4 or more prior lines of treatment they found in this study. What about rituximab? Rituximab, there was a lot of excitement about rituximab a couple decades ago in ITP. It's relatively easy to give a patient 4 weekly infusions, or you can even do rheumatologic dosing and give them 2 infusions of rituximab a couple weeks apart. And that will provoke a response in about half, 60% of patients that are in the pure second line stage. Later, if you use it later in third, fourth, fifth lines, your success rate will be lower. But the reality is that rituximab, we now know from long-term follow-up, really isn't curing anyone. It's a Band-Aid that lasts for a long time. And that's not necessarily a bad thing, but the reality is that, at 5 years, the rate of rituximab sustained response is only about 20%, and that approximates the rate of spontaneous remission in patients with ITP. So an option, but not free lunch, not a free cure. And in fact, actually, there's some data from the group in France now showing that using rituximab may actually make the disease a little bit more challenging to treat. It may actually advance the immune dysregulation ultimately in ITP and make it more difficult to treat down the line. So thrombopoietin receptor agonists are obviously a very important therapeutic option in ITP these days. With multiple agents approved for ITP, we have riplastim, which is a subcutaneous injectable once weekly agent. We have avatrombopag and L-trombopag, both approved for ITP as well. And these are oral drugs, small molecules. Riplastim binds to the extracellular portion of the thrombopoietin receptor, and the oral drugs bind to the transmembrane portion. There's some slight differences in downstream effects on that basis, with riplastim mostly stimulating mature megakaryocyte precursors to differentiate and produce a lot of platelets, and L-trombopag and avatrombopag seem to act a bit earlier to stimulate even earlier precursors. But nevertheless, the ultimate result is increased platelet count within about a week. So let's compare the thrombopoietin receptor agonists in ITP. So as I mentioned, the obvious, we have the subcutaneous drug riplastim, and all the drugs that end in OPAG are oral. L-trombopag and avatrombopag are approved in the US for ITP. Hetrombopag is a drug available in China that is also approved in ITP. To my knowledge, not available outside of China yet. And lucitrombopag is a drug that is available in a number of places, including the US, but not approved for ITP. Like avatrombopag, lucitrombopag is approved for thrombocytopenia of chronic liver disease. Avatrombopag approved for both thrombocytopenia of chronic liver disease and ITP. So pediatric use. We have lots of data on riplastim and L-trombopag. We recently got a phase 3 study that was presented at EHA last year on avatrombopag, which was a plenary talk at EHA, avatrombopag and pediatric ITP. So we anticipate approvals for that soon, but we don't have it yet. Avatrombopag has a number of advantages over L-trombopag and hetrombopag, and certainly over imiplastim as an oral drug. We can talk about that momentarily. Dietary restrictions is one of those advantages. So rimiplostim is not oral. It doesn't matter what the patient's diet is. L-trombopag, it very much does matter. And L-trombopag absorption is dramatically reduced, over 60%, when the patient has any significant intake of calcium, magnesium, or other divalent cations within 2 hours before or after taking the L-trombopag. Also, dietary fat may reduce its absorption. And so avatrombopag is an oral drug that does not have that challenge, which is a nice aspect to it. Hetrombopag, this Chinese TPORA, does have the same complication of L-trombopag in that it has dietary impacts on absorption. Now, the fact that those divalent cations reduce L-trombopag absorption and hetrombopag absorption, for that matter, also plays a role in iron chelation. So both L-trombopag and hetrombopag are actually rather potent iron chelators, which is not so good in ITP, right? When we're treating young women who are menstruating or children, we don't want to make them iron deficient. And this is exactly what happens if you use L-trombopag for a long period of time and you're not monitoring the patient's iron. So you have to be very careful when you use L-trombopag and monitor iron to make sure you're not making the patient iron deficient because they're getting an iron chelator. But in certain situations, like in aplastic anemia, for example, that iron chelation effect is a good thing. Or an MDS, right? If we use L-trombopag to raise the platelet count, we're plenty happy to chelate iron in patients receiving regular transfusions. Known hepatotoxicity. So rimiplostim is a no, L-trombopag is a yes, avatrombopag is a no, and hetrombopag is a yes. You're starting to see a pattern emerge, I imagine, with the L-trombopag, and hetrombopag is very similar to L-trombopag. So there is about a 10% risk of hepatotoxicity with L-trombopag. Most of the time that manifests as transaminase elevation within the first year of initiating the L-trombopag. And so monitoring transaminases monthly for the first year is indicated in patients receiving L-trombopag. Other safety considerations, so obviously important to consider drug-drug interactions as with any drug, and this is for the oral TPORAs, not something you have to worry about with rimiplostim. Thromboembolism is something that, everybody is worried about with TPORAs. There has not been any statistically significant higher risk of thromboembolism in any randomized controlled trial of TPORAs, and this has been there's been many RCTs. The same is true if you do meta-analyses of these RCTs, because certainly the RCTs were not powered to look for thromboembolism. There have been in some long-term observational studies a suggestion that being on these drugs for years may have an increased thromboembolic risk, but really truly what the main cause of thromboembolism in ITP is ITP. So ITP is a bleeding disorder that also increases thromboembolic risk. And so, we recognize that these patients are at higher risk than the general public for thromboembolism because of their disease, not necessarily because of thrombopoietin receptor agonists. Rebound thrombocytopenia is a major concern, particularly with rimiplostim and ITP. If you just stop, abruptly, and the prescribing information for these drugs in many countries, and including the United States, is really awful, in that it recommends holding the drug for a platelet count of greater than 400,000, which is a terrible idea. If you hold a thrombopoietin receptor agonist, you're likely to precipitate a crash in that patient due to rebound thrombocytopenia. I never hold pretty much ever unless a platelet count is well over 1 million. And I will reduce the dose of the drug. I may reduce the dose of the drug 70%, but I will reduce the dose of the drug, give them just something, a whiff of drug, to prevent them from crashing. Myelofibrosis is something that, everybody initially early on in this area with these drugs was worried about. It turns out that if you give patients thrombopoietin receptor agonists for a long period of time, you increase reticulin fibrosis in the marrow, but it's reversible. So you stop the drug, the reticulin fibrosis will go back to the patient's baseline. What these drugs don't cause is collagen fibrosis, which is irreversible. That's problematic. So if you were to look at peripheral blood films and all of your patients with ITP receiving thrombopoietin receptor agonists for a long period of time, you would eventually see some tear dropping. You would see it start, and some people who do this become very anxious. But if you do a bone marrow in that patient, you'll see they have 2+, 3+ reticulin fibrosis. But if you stop the drug, that goes away, and it's not relevant. So it's sort of riling yourself up for no particular reason. So I do not monitor peripheral blood films or bone marrow biopsies in patients receiving these drugs for a long period of time, and that is part and parcel with the standard of care. So I mentioned L-Thrombopag and Hetrombopag have hepatobiliary toxicity. Neutralizing antibodies can be observed with Remiplastim, and they, in theory, could cause inefficacy of the drug. It's extremely rare, and most importantly, there is no cross-reactivity of any anti-Remiplastim neutralizing antibodies with native thrombopoietin. Plasma discoloration happens in patients receiving L-Thrombopag because L-Thrombopag itself is a reddish brown powder. Okay, and so if you give L-Thrombopag at higher doses, especially in patients that have small bodies, a 40 kilogram patient getting 75 or 150 milligrams of L-Thrombopag, max dose L-Thrombopag in ITP or aplastic anemia, you can see that their skin can kind of turn a little bit. If they have fair skin, it can turn a little bit almost muddy. Their sclerae can get kind of muddy or reddish brown. And this can be, the patient might not like the fact that their eyes are looking a different color. Also, the lab can call you and say this patient has acute hemolysis, and they don't. It's just the L-Thrombopag. This is an example of a patient of mine that was receiving L-Thrombopag, a small 50-something-year-old woman, and you can see her plasma is reddish brown discoloration next to a normal a plasma sample. So technically speaking, the prescribing information for L-Thrombopag and Hetrombopag advise lower starting dose in persons of East Asian ethnicity. This is probably overblown. There is some slight differences in metabolism, but in my experience, and we're recognizing more and more that we're probably under treating patients if we start patients at 25 milligrams of L-Thrombopag instead of 50 who have East Asian ethnicity. At this time, I pretty much start everybody at the same dose, irrespective of ethnicity. But just to mention that. L-Thrombopag needs to be dose reduced in hepatic dysfunction, as does its sister drug Hetrombopag. Remiplastim and Avatrombopag don't need to. Increased thrombosis risk in chronic liver disease. So, Remiplastim has not been, rigorously evaluated in chronic liver disease. But as far as we know, it does not have an increased thrombosis risk in these patients are special increased risk. So L-Thrombopag actually does, on the basis of the Elevate study, which was a study that was published in 2012 after being stopped prematurely for excessive thromboembolism in the L-Thrombopag arm. This was patients with chronic liver disease that were getting L-Thrombopag around the time of a procedure, an invasive procedure to raise their platelet count for the procedure. Avatrombopag and also Lucitrombopag had similar clinical trials as Elevate and did not show any increased thromboembolic risk in the TPORA arms compared with the placebo arm, and so may be safer in that regard. Same is true for Hetrombopag, and that we don't have evidence that it's particularly problematic in chronic liver disease. What about use in pregnancy? Remiplastim and L-Thrombopag, both, there is data. It's not extensive. It's retrospective. It's more abundant with Remiplastim because Amgen, the manufacturer of Remiplastim, had a pregnancy surveillance program that included, I think, about 80 patients. That was published that showed that there was not any signal for increased any sort of complications related to Remiplastim in mom or baby. We don't really have this data for L-Thrombopag and Hetrombopag. And again, these drugs are not approved for use in pregnancy, but there is data now, particularly in the third trimester, suggesting that use of Remiplastim or L-Thrombopag may be reasonably safe. Although use while nursing can cause, while breastfeeding can cause the drug can enter the breast milk and cause an increase in the baby's platelet count, and also almost like a blast-like picture on the baby's peripheral smear. This was presented at ASH a couple years ago. So ideal not to use these drugs during breastfeeding. So in terms of the oral agents, the prescribing information for all of these in ITP says dose them once a day at baseline. But Avatrombopag, the prescribing information actually so there's only one dose of this drug, 20 milligram, and you reduce the number of days per week that the patient receives the dose if you down titrate it. So you go from 20 milligram daily to 20 milligram 3 times a week, twice a week, once a week, which is convenient for patients and that they don't have to get another prescription. Het Trombopag, no. L Trombopag, technically no, but yes, actually, you can give L Trombopag like avatrombopag less frequently than once daily. Again, the pharmacodynamics of these drugs in stimulating platelet maturation, megakaryocyte maturation and platelet release in the bone marrow is such that they don't need to be dosed every day. And the half-life of avatrombopag is 19 hours. It's 35 hours for L-trombopag in patients with ITP. So, you can get away with giving it less frequently than once daily. And again, this is the avatrombopag prescribing information for the US, showing that you just go down to 3 times a week, twice a week, or 40 milligram once weekly, and then 20 milligram once weekly. And I do have a few patients that have managed to get down to 1 dose of this a week. Alternative intermittent L-Trombopag dosing in ITP is something that we published on and other groups have published on subsequently, basically showing that you don't need to give L-Trombopag every day. You can give it 5 times a week, 3 times a week, 4 times a week. You can titrate down, not by the pill strength, but by the number of days a week the patient takes the drug. This is not optimal for everyone, right? Some people are adherence can be challenging when they're not taking it every day. It's better to just reduce the dose and have them take it every day, but certainly does work for some patients. Sometimes I get asked, are there any predictors of, before I start these drugs, which can be expensive, is there any predictor that a patient will respond or not respond? And we did look at endogenous baseline thrombopoietin as a predictor of thrombopoietin receptor agonist response in ITP, and we did find that the higher the baseline thrombopoietin, very analogous to using erythropoietin to predict response to erythropoiesis stimulating agents, the higher the baseline thrombopoietin, the less likely, the lower the likelihood of response. Most patients with ITP have a normal thrombopoietin level or only a slightly elevated thrombopoietin level. Remember, thrombopoietin is produced constitutively by the liver and metabolized by platelets and megakaryocytes. And while patients with ITP don't have much platelet mass, they have plenty of megakaryocyte mass. So most patients still have a normal thrombopoietin level. And when their level is normal, most patients respond very, very nicely. In this assay, a normal thrombopoietin level is 100. Okay. As you increase your thrombopoietin level, your likelihood of response starts to drops off faster with L-trombopag than with romiplistim, as we found. After a discussion, so going back to case 2, after a discussion of the treatment options, the patient prefers an oral thrombopoietin receptor agonist, so is prescribed L-trombopag, promptly recovers his platelet count, maintains it at a goal of 100 to 200,000. LFT monitoring shows no abnormalities. He does well in L-Trombopag for 13 months until his routine platelet count monitoring reveals a drop to 20 to 30,000 over 3 consecutive measurements. He admits that he's been taking his L-Trombopag with breakfast as he stopped intermittent fasting, his previously intermittent fasting. He struggles with the dietary restrictions over the next year or so, with 2 crashes during that time. And really, for optimal L-Trombopag absorption, you want the patient to be fasted for 3 hours before taking the medicine, 3 hours after taking the medicine, minimum 2 hours before and 2 hours after, because patients don't know what has calcium in it. Green leafy vegetables have calcium in them. It's not just dairy. There's lots of things that have calcium, magnesium in it. All right, so this patient's not doing so well in L-Trombopag. So could we switch him to a different thrombopoietin receptor agonist? So I have here switching thrombopoietin receptor agonist ITP is old news. It is old news. We've been doing this now for a long time, well over a decade. This is a fun figure showing a patient of ours that at baseline had platelet counts 15,000 range, was bleeding, needed to be started on medication. This was many years ago. They were enrolled on a clinical trial of avatrombopag. That's why the avatrombopag dosing is a little bit strange. Platelet count recovered very nicely to goal between 100 to 200,000. Then the avatrombopag trial ended, and there's no open label extension, and they wanted to continue on an oral drug, so they would switch to L-trombopag, and L-trombopag didn't work so well, despite the fact that avatrombopag worked fine. And so ultimately they were switched from L-trombopag to romiplistim, and romiplistim worked a little bit too well at first with 3 microgram per kilogram dosing, and the patient did just fine on very low doses of romiplistim. And I like this figure because it recapitulates a little bit the relative potency of these drugs in healthy subjects. So we don't have good data evaluating relative potency in patients with ITP, but if you look at the healthy subject studies from a long time ago, maximal doses of remiplastim it provoked platelet counts about 8 times higher than maximal doses of L-trombopag, and maximal doses of avatrombopag provoked platelet counts about 3 times higher than maximal doses of L-trombopag. So if you have a patient with ITP and they're not doing well on remiplastim or L-trombopag, or they're tired of injections on remiplastim, or they can't do the dietary restrictions on L-trombopag, or their efficacy is just not adequate, even if they're doing everything right, you can switch, and the chances of the other agent working are quite high. In this meta-analysis, it was about 80%. We did some additional study with avatrombopag, looking at switching between L-trombopag or remiplastim and avatrombopag, and we found the same thing. The likelihood of response was good, even, I mean, irrespective of the indication for switching, including in efficacy of the drug. And platelet counts improved really quite markedly with switching. Most patients that were on concomitant ITP medications with their thrombopoietin receptor agonists were able to discontinue those after switching to avatrombopag, including 63% of patients receiving chronic corticosteroids. And we can see here the platelet counts before and after switch in all patients in panel A, and those patients that were switched for ineffectiveness of the prior thrombopoietin receptor agonist in panel B. Durability after platelet response to durability after switching of platelet response was quite good, with response maintained 84% of the time on treatment. A little bit lower if they were switched for ineffectiveness, but if they switched for convenience or adverse events of the prior drug, it was quite high. And no difference if switched from L-trombopag or remiplastim. And again, this is just generally speaking durable. 13 patients over years of treatment received had at least one loss of response. And you can see here the red is when they had a loss of response time, loss of response platelet count less than 50,000. And again, you don't necessarily need a platelet count of greater than 50,000, but that's what response was defined as in the study. Whereas the green was when the patients were above that response threshold. So there was a phase 4 study of switching L-trombopag or remiplastim to avatrombopag that was presented at ASH last year. And the primary endpoint of the study wasn't platelet counts, wasn't anything related to that. It was actually patient satisfaction. So patient satisfaction scores in all domains in this treatment satisfaction questionnaire for medication were significantly and clinically relevantly improved in avatrombopag as compared with remiplastim or L-trombopag. So patient assessment of effectiveness, side effects, convenience, and global satisfaction. So again, the newest TPORA and ITP, avatrombopag, and the most convenient. All right, so bottom lines for switching, it doesn't matter which drug they're on. They could be on avatrombopag, it stops working, you can switch them to L-trombopag or remiplastim. Chances are they will respond to that second agent, and the durability is good. So going back to case 2, the patient is switched to avatrombopag, promptly recovers his platelet count, maintains it in the 100 to 200,000 range, does well on oral avatrombopag for 4 years. He then asks if he really has to take this medication for the rest of his life, or it might be safe to stop at some point. So let's talk a little bit about quality of life in ITP and tapering of thrombopoietin receptor agonists in ITP. So, ITP, it's important to remember that ITP it's not a malignancy, but it is still a disease with significant impact on quality of life, and not just for things like anxiety, and not just because patients get admitted to the hospital with low platelet counts, and not just for drug toxicity, but the disease itself causes a lot of fatigue, all right? And actually, the mind fog in patients with ITP in one well-done study was shown to be similar to patients with cancer receiving chemotherapy, all right? So there is a systemic inflammation aspect of this disease that causes constitutional symptoms and mind fog that's really not fully appreciated. And we often don't talk to patients about it because we're so fixated on bleeding and platelet count. So, in this IWISH study, which was a humongous international study that had 1,507 patients with ITP, 472 physicians treating ITP from 13 countries, showed that most patients, 85%, reported reduced energy levels. Half reported persistent fatigue. 75%, their ability to perform daily tasks was limited. Half believed ITP had a substantial impact on their emotional well-being, so on and so forth. Half had reduced or considered reducing their work hours because of ITP. And physicians, while most when the physicians surveyed in this study, while most things aligned, not everything aligned. The physicians really underestimated the severity and the importance of fatigue in patients with ITP. So, looking at the IWISH study, the treatment goals for patients versus for clinicians, there is some overlap here, but there's a lot of incongruency here as well. So it's important that we not forget about those quality of life aspects of ITP. All right, so the patient's asking, does he really need to be on avatrombopag forever? So let's talk about tapering. So there's a rich history of tapering thrombopoietin receptor agonists in ITP in terms of sustained response off treatment rates. Multiple retrospective studies done early on, a decade ago or more, in many cases showed a rate of about a third. You taper a patient off who's been on these drugs for a long time. Their platelet counts have been good, above 100,000 generally for extended length of time. If you try to taper them off of the thrombopoietin receptor agonist, about a third of patients would maintain a sustained response off treatment, a platelet count of greater than 30,000 without bleeding and no need for treatment. Good enough. So in a phase 2 prospective study of ripplestim tapering, the rate was, I won't go through all these details, but again, the rate was 32%. There's again that 1/3 number. This was 75 patients. In a phase 2 prospective study of L-trombopag tapering called the TAPER study, 105 patients. Again, we have a 31% rate of sustained response off treatment through month 12. And these studies were very protocolized in how patients would taper. And so, patients had to achieve a complete response, platelet count above 100,000. They then had to maintain a stable platelet response, a platelet count above at least 70,000 for 2 months or longer. And then they had to successfully taper without dropping below 30,000 without bleeding. And then they were judged as being in sustained response off treatment. There is also a prospective multi-center thrombopoietin receptor agonist tapering study called Stop-A-Go, which is the only study that showed higher rates at a 56% rate. I think this study may have just had a favorable population of patients. But nevertheless, this study also did look at single-cell RNA sequencing, finding that there was enriched tumor necrosis factor alpha signaling via NF-kappa B signatures on CD8 positive T cells of patients that did not have sustained response out of treatment. Again, showing that these patients probably have a more aggressive immune phenotype than those patients that did achieve sustained response off treatment. Again, this is sustained response and sustained complete response off treatment in the Stop-A-Go study. So bottom line, if your patient's doing well, their platelet count's above 100,000 for an extended period of time, it's reasonable to try tapering. It's not really, we don't really have good predictors of response in this regard that are ready for prime time, but you have about a 1 in 3 chance of success. So, and if the patient fails, they can always restart the drug. All right, case 3. A 47-year-old woman with chronic ITP presents for evaluation. She progressed past first-line therapy after 1 month and has been treated with L-trombopag, ripplestim, avatrombopag, rituximab, and fostamatinib over the past 10 years since, with variable response. Most controlled her disease for a period of time, but ultimately failed her. She has not undergone splenectomy and is extremely resistant to this surgical option. She still responds to steroids and IVIG, though the duration of response to both is relatively short-lived. Her platelet count today is 12,000 and she has petechiae on her legs. So what do? Do we begin chronic steroids? Obviously, we'd like to avoid chronic steroids as much as possible, and this should really be avoided as much as we can. Do we give IVIG every 2 weeks? It's inelegant. It would work. It's a lot of IVIG and it's a lot of infusion time, but it could work. Do we try a combination therapy? That seems pretty reasonable, like combining a thrombopoietin receptor agonist with an immunosuppressant drug like mycophenolate mofetil. Do we refer for splenectomy even though she really doesn't want it, or refer for a clinical trial? So again, multiple correct answers here just to spur thought. If a clinical trial is available, that would be my first choice. If not available, then I would try combination therapy. So combination therapy in ITP comes in multiple different flavors: thrombopoietin receptor agonist plus an immunosuppressant, thrombopoietin receptor agonist plus low dose prednisone, which would be 5 milligrams of prednisone daily or less, just a whiff of prednisone, and you'd be surprised sometimes how well that works. Basically, a dose that is not unsafe to be on for the long term. Thrombopoietin receptor agonist plus a second thrombopoietin receptor agonist, which can sometimes work, but again, that approach is quite a bit more expensive. And there's mixed literature on this, right? So most of this is case reports and case series reporting combinations, and people aren't rushing to publish their failed combinations, right? People generally publish what works, and so there's a bias toward reporting successes in the literature for combination therapy. Obviously, access can be challenging. There's a lot of studies in the last year coming out combining avatrombopag and fostamatinib, both expensive newer drugs in Europe, because the manufacturers of those drugs made that possible. Particularly manufacturer of fostamatinib made that possible to combine those drugs, made the drug accessible to patients, particularly in Spain. Whereas in the US, I can't get avatrombopag and fostamatinib for most of my patients because both drugs are very expensive and insurance will only cover one. But you could try a TPORA plus a legacy immunosuppressant like mycophenolate or azathioprine, and this approach can be successful. And this is a case-by-case kind of thing. All right, so let's talk about emerging treatments in ITP. Steroids, splenectomy, and salvage to numerous targeted therapies in 2 decades. That's where we are now. We have numerous We have thrombopoietin receptor agonists, we have fostamatinib as a spleen tyrosine kinase inhibitor, but there are numerous other therapies, right, that are coming in the pipeline. So we have the neonatal FC receptor antagonist efgartigimod, which is had clinical trials done, and the Advance IV study, phase 3 IV efgartigimod study was presented as a plenary at ASH in 2022. The advanced subcutaneous or SC study of efgartigimod and ITP unfortunately was negative. So the advanced next study of efgartigimod and ITP is happening now. That's a second IV study. So this drug would be limited to IV use, but I'll show you some data on it. Rilzabrutinib, oral Bruton's tyrosine kinase inhibitor, has completed pivotal phase 3 study in adults. The pediatric arm is still ongoing. The adult arm was presented as a plenary at ASH last year. Ianalumab is a BAFF receptor antagonist or B-cell activating factor receptor antagonist. I'll talk about this. This drug is in the largest ITP clinical trials development program ever. Povetacicept is a BAFF and APRIL antagonist. Again, BAFF and APRIL are critical cytokines in B-cell maturation. And this is an extremely potent subcutaneous drug that's currently being evaluated in a basket study. Anti-CD38 antibodies that we've been using for a very long time to treat plasma cell neoplasms are now being evaluated in autoimmune diseases, particularly autoimmune hematologic diseases, including ITP. Drugs like mezagitamab, which is a new agent that's being evaluated, daratumumab, which we've had for a long time, and a drug called CM313. And then there's some novel spleen tyrosine kinase inhibitors. So fostamatinib was the first spleen tyrosine kinase inhibitor to be evaluated and approved in ITP, and we have other drugs, savolitinib and cevidoplenib, that are coming out of China that are being evaluated right now in studies. So let's talk about efgartigimod, neonatal FC receptor antagonism. So what is the neonatal FC receptor? We don't think about this very often in clinical practice. The neonatal FC receptor is a critical receptor on endothelial cells that helps in recycling IgG. So IgG without the neonatal FC receptor has a half-life of about 7 days. With it, it has a half-life of about 21 days. So this receptor is very important in preserving IgG and saving it from destruction in the lysosome. Okay, so in this animation, we have efgartigimod blocking some of these neonatal FC receptor sites, and antibodies that are present in the endosome then get directed to the lysosome for destruction. And we have fewer antibodies that are recycled. Okay, so this drug reduces the half-life of IgG to about 7 days. Why is that good? That's good because in humoral autoimmunity, like in ITP, where you have platelet autoantibodies, you destroy a bunch of the platelet autoantibodies. And turns out that when given IV, efgartigimod works nicely in a subset of patients with ITP to improve their platelet counts, as is seen in this RCT of very relapsed refractory patients with ITP. We look at their IgG levels over time. We see that drops about 60% in the efgartigimod arm, which may be a bit of a happy medium. We don't want to drop patients' IgG levels so low that they're getting infections. And efgartigimod studies in ITP and in other indications have not shown a significant increase in infection risk with use of the drug. But 60% may be good enough to get rid of enough of the pathologic autoantibodies to make a difference in the disease pathophysiology, but not so low that it causes infections in patients. All right, BTK inhibition. So BTK inhibition is a workhorse in hematology and lymphoid malignancies in particular, as we know, with multiple impacts that these drugs have on the immune system. And in particular in ITP, they cause B cell depletion, they inhibit plasma cell differentiation and autoantibody production, and they block phagocytosis, all relevant for ITP treatment. In a phase 1/2 study of rilzabrutinib, a BTK inhibitor being developed specifically for autoimmune diseases and not for malignancy, 40% of patients who had severely relapsed refractory ITP responded to rilzabrutinib. Patients who responded had rather remarkable stability in their platelet counts, which was also shown in the open label extension that was published last year. Patients remarkably staying between platelet counts of 60,000 to 100,000. With thrombopoietin receptor agonists, you often see a fluctuation that can, be a roller coaster up and down, and we don't see this with rilzabrutinib. And then, the response rate of 40% was not really different, irrespective in this highly relapsed refractory patient population. So that's an impressive number in this patient population. This is not different, irrespective of the different subgroups, patients with a splenectomy, without a splenectomy, whether they were chronic or not chronic ITP, previously treated with more than 4 therapies or not, the response rates were similar. You might say, giving a BTK inhibitor in ITP seems like a bad idea because these patients have bad thrombocytopenia and BTK inhibitors can inhibit platelet function, particularly drugs like ibrutinib and acalabrutinib. Well, rilzabrutinib, also called PRN1008, is much more selective in terms of its impact on the kinome. And platelets on this drug are able to bypass the BTK lesion with bypass pathways and have normal aggregation. If you look at ibrutinib in healthy volunteers, you see that platelet aggregation to multiple agonists is reduced. But you look at rilzabrutinib in healthy volunteers and patients with ITP, and there is no impact on platelet aggregation. So the LUNA-3 study was the study that was presented at ASH as a plenary just this last year, which randomized patients to rilzabrutinib 400 milligram BID or placebo, and monitored them for 24 weeks, and then patients could enter an open label extension. And this has not been yet fully published as a manuscript, but 133 patients randomized to rilzabrutinib, 69 to placebo, similar baseline characteristics. Median of 5 prior ITP therapies, median duration of ITP at 8 years. So again, a heavily relapsed refractory population. Platelet response achieved in 65% of the rilzabrutinib patients, 33% of the placebo patients, and durable response in 29% of the rilzabrutinib and 0% of the placebo. Less than half the rescue therapy given in the rilzabrutinib arm. Significant and clinically meaningful improvements in physical fatigue according to the ITP patient assessment questionnaire, which is the first time this has ever been seen in a clinical trial of a medication, possibly because of the anti-inflammatory effects of rilzabrutinib. More diarrhea, more nausea, and more headache in the rilzabrutinib arm. This is a tyrosine kinase inhibitor, does have adverse events. But people ask me, it seems like a lot to give a BTK inhibitor to a patient with ITP. Rilzabrutinib is not like BTK inhibitors in malignancy. This is like a BTK light. It's like a diet BTK inhibitor. It's gentler. And so the side effect burden is less. So I'll talk about spleen tyrosine kinase inhibitors. Again, the spleen tyrosine kinase is a critical kinase in macrophages and other phagocytes that is important in phagocytosis of platelets that have been opsonized by IgG and complement, and blocking it reduces that phagocytosis. And this very simply, it's an oversimplification, but I like to describe to patients that this is like an oral splenectomy in some ways. It's like shutting down the phagocytosis of these cells in the spleen without taking out the spleen. So fostamatinib was our first spleen tyrosine kinase inhibitor, and this was evaluated in a heavily relapsed refractory population and found 43% overall response rate, 18% stable response rate, numbers that at the time were thought to be not very impressive, but really realistically now with the benefit of additional studies in this population are actually perfectly reasonable. And like most treatments, the line of therapy in which you use fostamatinib matters. If you give it early on in the second line, the response rates are in the 80s. If you give it later on in the fifth line, the response rates are in the 30s. So it really just depends on when you're giving it. But patients who respond have a durable response, as we can see in the figure on the right. Sovleplenib, I'll just briefly mention sovleplenib and cevidoplenib, which are two new spleen tyrosine kinase inhibitors that are being developed. They may have lower side effect rates. They may have higher response rates than fostamatinib. This was a phase 2 study of sovleplenib and ITP that was published a couple years ago, and then phase 3 study. This was out of China, both these studies. That showed pretty reasonable rates of response of about in the 40% range for people receiving sovleplenib compared with placebo. And spleen tyrosine kinase inhibitors, particularly fostamatinib, cause a lot of hypertension. They again, as TKIs, you see TKI side effects, you see rash, you see diarrhea, and these newer drugs, including sovleplenib, may be less likely to cause side effects. So plasma cell-directed agents, CD38 monoclonal antibodies. We have daratumumab now. I've had it for a long time. Daratumumab is a very potent plasma cell depleting agent that can deplete long-lived plasma cells in the bone marrow. Same thing is true for these newer drugs that are being developed specifically for autoimmune disease, like mezagitamab, which I'll get to in a moment. This was a safety run-in for an investigator-initiated study of daratumumab and ITP, just 4 doses. And you can see that after 4 doses, everybody responded. 2 of the patients went back to their low platelet counts after receiving no further treatment. 1 patient was still in response at week 24. So mezagitamab was presented. The data for mezagitamab was presented at ISTH. Mezagitamab in phase 2 ITP was presented at ISTH this last year with really quite favorable results. So if we look at the platelet response rate in the highest dose group, it was about 90%. Complete response rate was about 80% in the highest dose group. Compared with 0% in the placebo arm, 80 to 90% response rates in the highest dose group across the board for mezagitamab, and we can see a clear dose-dependent response of platelet count improvement with mezagitamab in this study. And importantly, the study wasn't powered to look at reduction in bleeding events, but there was clearly a reduction in bleeding events, no bleeding treatment-emergent adverse events in the patients. Excuse me, in the patients receiving mezagitamab at the highest dose, compared with about 50% of the patients receiving placebo. CM313 is another anti-CD38 monoclonal antibody that is in evaluation for ITP. It's being evaluated as a drug, again, out of China, that in a phase 1/2 study that was published in the New England Journal of Medicine. A relatively small study, 22 patients, showed some promising results after 6 months of treatment. All right, so I'll finish up with just talking about inhibition of these cytokines BAFF and APRIL and inhibition of the BAFF receptor. So ianalumab is also called VA736, is a new monoclonal antibody that is currently in the largest ITP clinical trials program, drug development program that's ever existed. Ianalumab is in 2 large randomized phase 3 pivotal trials in ITP right now, and it has finished a phase 2 single-arm study. This drug works via blockage of the B-cell activating factor receptor, which is absolutely critical in activation and differentiation of B cells and induction of long-lived plasma cells. It also is an extremely potent B cell depleter, much more so than a drug like rituximab or ofatumumab or obinutuzumab. This is just a very, very potent B cell depleting drug. And so the first the first of 3 studies that's ongoing in ITP for this drug is called VHIT-1, and this is evaluating eonalimab plus corticosteroids versus corticosteroids plus placebo in first-line ITP. So the idea with this drug is, unlike every other drug in ITP, which is evaluating relapsed refractory patients, can we change the course of disease? Can we modify the course of disease in ITP such that instead of only 20% of adults with ITP having a remission after receiving first-line treatment, can we increase that to 40% or 50%, a better number, with 4 infusions of eonalimab early in the disease course, before there are many T cell clones in these patients, which they develop over time? We know that if you've had ITP for 10 years, your T cell repertoire is much more diverse than if your autoreactive T cell repertoire is much more diverse than if you are newly diagnosed. And so the idea is, can we hit things early? And prevent the development of those long-lived plasma cells and redirect the immune system early on. VHIT-2 is similar concept, but in pure second-line patients, and instead of corticosteroids, it's L-trombopag. So eonalimab plus L-trombopag versus placebo plus L-trombopag. Okay, and again, looking in the primary endpoint, both these studies is sustained response off treatment, time to treatment failure. Essentially, not so many platelet counts above 50,000 during a certain window of time, like every other ITP study, but will these drugs change the course of disease in these patients and make it such that patients don't need therapy? Their platelet counts remain above 30,000. They're not bleeding. Everything is fine for long periods of time. VHIT-3 was a phase 2 study that was just a proof of concept study to a single arm study to look at eonalimab in patients in 3rd line and beyond, so similar to many of the other agents in ITP. And this study was presented, interim analysis was presented at ASH this last year. Response rate 50% in the patients that had completed treatment and were evaluable, and then a favorable safety profile. All right, so with that, I'm happy to take questions.
Thank you so much, Dr. Hani. Wonderful lecture, fantastic lecture. It was very good
My pleasure.
listening to you and learned quite a lot from you. Thanks a lot.
Yes,
And
no
I've
problem.
request all our discussants to please put the hand raised sign so that we can start our question session with Dr. Hani. Fine. So there are no hand raised signs. Sir, can you please unshare your screen so that we can easily see each other?
Oh, sorry, of course.
There are some questions coming up from the audience. The first question is from Dr. Sanjukta Rao. Do you recommend testing for IgA deficiency in asymptomatic adults before initiating IVIG?
That's a great question. The short answer is yes. I do quantitative immunoglobulins in all patients that I've diagnosed with ITP, both to look for IgA deficiency before giving IVIG, and also to look for CVID as a potential, secondary cause of ITP. Some CVID or another, immune complication or immunodeficiency that could be leading to a secondary ITP.
Thank you so much, sir. Another question from Dr. Mehak Trehan. He has a young woman with chronic ITP on TPO receptor agonist planning for pregnancy. Question is how to approach and management options in pregnancy.
It's such a challenging issue, especially when the person is on the TPO receptor agonist and doing well. Right now, we don't have enough data to say you should continue on the TPO receptor agonist, particularly during the first trimester. There are a few cases have been published of people getting L-Thrombopagan and Ripplestim in the first trimester, and it seems to be okay, but I would not recommend it. So I would say try to taper that patient off of their thrombopoietin receptor agonist, see what their platelet counts are, especially if they've been on it for a long time. Their platelet counts may be acceptable. If they're not bleeding and their platelet counts above 30,000, that may be acceptable for the bulk of pregnancy, and then you can give them IVIG or prednisone prior to delivery, so they can get epidural anesthesia and get their baby delivered. If you know the patient does not respond to prednisone or IVIG, that is a more difficult situation. I would reach for azathioprine. I would try azathioprine, which is safe in pregnancy. Um, if the patient is non-responsive to all of these things and only responsive to a thrombopoietin receptor agonist, it's a difficult decision, right? It's something that needs to be discussed whether it's appropriate for that patient to try for pregnancy. If you pinned me down and said you have to pick the patient is going to get pregnant. We can't stop them. You have to pick a thrombopoietin receptor agonist. I'd probably pick Remiplastim, just because it is going to be relatively less exposure to the fetus as a peptibody drug versus a small molecule.
Thank you so much, sir. Second question he has is in our resource poor countries and the resource limited settings where we don't have any access to the new medications like avatrombopag or heterombopag, and the cost is a big issue even for L-Thrombopag romiplostin. Splenectomy is being afforded in the government settings at affordable cost and one-time cost. How would you advise we define the patient selection in such cases? Who should go for splenectomy at once and who should
That's,
not go for splenectomy?
that's a great question. So splenectomy is a perfectly reasonable treatment for ITP. This is a simple reality. It does work for many patients. If you have a patient that is they've had disease for at least a year. So I try to avoid splenectomy in the first year because, again, is a real remission rate, and that's consistent with the guidelines. And I try to use medical therapy in the first year to maintain an acceptable platelet count, if at all possible. But, sometimes not possible. Sometimes, the patient is at beyond a year and we're talking about splenectomy. In that case, the patients that have failed multiple treatment lines already, whether it doesn't have to be thrombopoietin receptor agonists. It could be rituximab, it could be mycophenolate, it could be azathioprine, it could be cyclosporin, it could be dapsone, it could be, there's many different drugs, right, that we use, immunomodulatory drugs that use, salvage sort of drugs in ITP that you can use if the patient can't afford a thrombopoietin receptor agonist or can't receive one. I just be careful about sending patients with multiply refractory disease to splenectomy because their chances are going to be low of success. Now, they may not have other good options, but just recognize that if their risk of success or their rate of success is 30 or 40%, chances are they won't succeed, and then they'll have a higher thromboembolic risk and a higher infection risk for the rest of their life. So there may be, an avenue to just accept a suboptimal platelet count so long as the patient isn't having regular bleeding. In terms of patients that are more ideal, right? Patients that have a generally responsive disease to other treatments are going to be more ideal. And in studies that have looked at this, older adults, particularly older men, tend to respond less to splenectomy than younger adults and women. So, that's um, uh, those are the predictors of response that we have assessed and have seen in studies, and the ones that we will quote.
Thank you, sir. Another question he has is ITP patients post-vaccine or post-COVID vaccine
Yeah.
on the clinical course and the response.
What a great question. So we know that if you have a patient with ITP and you give them a COVID vaccine, there is about a 5% chance they will have a legitimate crash, a platelet count less than 20 bleeding kind of crash. Okay. That is I mean, it's not a huge number, but it's not nothing. 1 in 20 patients will have a crash. About a third of patients will have a decline in their platelet count, but they won't quite crash. And these are patients, right, that are even receiving ongoing treatment. Okay, we're not just talking about patients that are doing well off treatment. Patients that are receiving treatment will still, these numbers apply to them as well. About a third of patients will have no change in the platelet count. About a third of patients, the platelet count actually go up after they get a COVID vaccine. Okay, so what do you do? What I do is I very simply, especially if it's early, if it's the patient's, the patient's gotten their first COVID. It's right now most patients have gotten more than one COVID vaccine, but if they're more naive to the COVID vaccine, I'll monitor. I'll get a platelet count immediately before the vaccine. I will give them the vaccine. I'll get a platelet count at 1 week, 2 weeks, and 4 weeks. And it's a few extra visits for platelet counts, but if the patient has not had a crash by the fourth week, the chances are they're fine. They're going to be fine. So, you know, um, uh, uh, patients that do okay with an initial shot, the initial 1 or 2 shots, they tend to be okay, and I don't feel as much a need to continue checking their platelet counts around every single COVID booster that they get. Patients that have had a crash, we actually have data to show that they may not have a crash the next time they have a COVID vaccine, but if anyone who's had a crash, I will monitor around their COVID vaccination. I'll monitor their platelet counts.
Thank you, sir. So once crash, you will monitor, and if it is not,
Correct.
it will not happen for the second time or any time.
Even if this, I mean, we haven't gotten out 10 years, probably eventually I might stop monitoring if they do well with recurrent vaccines. But if someone has had a crash, then I'm more apt to monitor. If someone has not ever had a crash and they've received their first couple COVID vaccines and they've been fine, then I don't feel the need to monitor either.
Thank you, sir. Another question from Dr. Sanjukta Rao. Uh, is there a risk of clonal evolution on L-thrombopag in ITP patients like post-treated aplastic anemia?
That's a great question. The short answer is no. There is not a risk. So there's T cell clones in ITP, which are not malignant clones, right? These are driving the immune response, and then there's the potential for myeloid, pre-malignant myeloid clones and malignant myeloid clones that could be harbored in the bone marrow. These drugs do not promote clonal evolution in patients with autoimmune diseases, patients with ITP. They actually don't promote clonal evolution in patients with MDS either. And I mean, at least as far as we can tell, the blast counts will rise in patients with MDS while the patient's on a TPO receptor agonist, but then they return to normal. And there's actually studies that show now 5 and 10-year follow-up of MDS patients treated with L-Thrombopoietin and riplastim that show no increase in evolution AML in the TPO-RA group versus the placebo group in those studies. But in ITP in particular, no. There's concern for leukemogenesis that was initially a concern a while back. We have long-term data now. It's not a concern in patients with ITP.
Thank you, sir. Sir, we have very important drugs in India, and we are prescribing left and right in Indian patients. We do prescribe azathioprine now also. We also prescribing.
Yep.
We are giving danazole, we are giving cyclosporin, we are giving
Yep.
cedarol.
Yep.
In today's ITP world, where do you fix all these drugs in today's ITP world?
I know, right? So these drugs just haven't been evaluated in randomized controlled trials in ITP. That's why they are not part of the, guideline-based paradigm for earlier use. Rituximab is not approved for ITP, but rituximab has been evaluated in randomized controlled trials, which is why it is positioned where it is in the guidelines and the treatment paradigm for ITP. So I think the reality is that it's art of medicine when using these drugs. Many of these immunosuppressive drugs do have a potentially greater side effect burden than a thrombopoietin receptor agonist or rituximab. So I think those have to be kept in mind, but they're also inexpensive and they can be quite effective. And so it's really a matter of, assessing the side effect profile of the drug, the patient, that you're dealing with and their other comorbidities. And when selecting a drug like azathioprine or like mycophenolate, or a patient, for example, that has gastrointestinal problems, that is inflammatory bowel disease, I'm not really excited to give mycophenolate because it causes a lot of diarrhea, right? So it's things like this. Your response rate in the unselected ITP patient for most of these drugs is going to be around 30 to 50%, which is not bad. And you just have to find a drug that works for the patient that they tolerate well. But there's no problems with this. And I will say that mycophenolate in certain countries is in the same level as rituximab and TPO-RAs for ITP. Like in the United Kingdom, for example, they use tons of mycophenolate. And so it's just a simple lack of really high quality randomized studies in this situation. I will say, because I don't want to forget, the FLIGHT study evaluated mycophenolate plus steroids versus steroids alone, and that was a randomized controlled trial. That was in ITP. That was published a while back. That was again in first line, so not as a single agent in second or third or fourth line. But that study showed a higher rate of sustained response off treatment in patients receiving mycophenolate plus steroids. The trouble is the quality of life was worse in the mycophenolate arm versus the steroid-only arm because of diarrhea and side effects to mycophenolate. So this is just balancing the toxicities.
Exactly. True, sir. Any role of bortezomib?
Bortezomib, yes. In patients with relapsed refractory ITP, there are case reports and case series of use of bortezomib. Bortezomib, I think the total number of patients with ITP in the literature is still in the teens, so this is not really well studied just yet. May have a more likely, may have a higher, longer term side effect profile than daratumumab, for example, or other plasma cell depleting drugs, but absolutely can work and is something that can be reached for in that relapsed refractory ITP patient that has failed more conventional therapies.
Thank you, sir. One question from Dr. Jyoti Sauni. In cases of chronic ITP, when we are comparing adults versus children with the use of TPO-RA, do TPO-RA in children has got similar response as adults?
That's a great question. Yet the response rate overall is similar in children. And, the toxicity concerns of, say, corticosteroids, right, are much greater in children, right? Because corticosteroids stunt growth and can cause a number of issues that in children that we don't worry about in adults, which make thrombopoietin receptor agonist use even more attractive for children with ITP. And the response rates are similar, and there aren't as good a there isn't as good a data in terms of tapering in children, but it's likely to work in children at least in similar capacity as it does in adults. So yes, they're rimiplostim, L-trombopag, and avatrombopag all been trialed in children with good responses.
Thank you, sir. Another question from Dr. Shrikant Marda. On the same note, when you are using TPO analogs or immunosuppressants in children, any contraindication for routine vaccination in children?
Such a good question. The short answer is no. Give the child their indicated vaccine, period. Anytime you administer a vaccine in ITP, there is a theoretical risk of a drop in the platelet count. Anytime. It's not just with COVID vaccine, it's not just with flu vaccine, it's any vaccine. But it doesn't matter. The benefits of the vaccine very clearly outweigh the risk of a platelet count drop. And to be quite frank, in children with ITP, it's much more common for children to have ITP and have single-digit platelet counts and not have any bleeding. Many of my pediatric colleagues, they just watch their children with ITP that have very low platelet counts because they don't want to subject them to toxicities of therapy. So, I mean, give indicated vaccinations. If a patient has had a clear crash in response to a vaccine, I would still give the next dose of that vaccine, but I would monitor the patient around the time they're receiving the vaccine and potentially treat them with something like IVIG or what have you if necessary.
Thank you, sir. Dr. Ninmya Thanda, your question.
Yes, thank you, Dr. Henny. I've learned a lot from you. I'd like to know how do you manage when ITP patients develop venous thrombosis?
What a great question. So challenging
Yeah.
situation in patients with ITP, but most important thing to remember is that patients with ITP have a thrombotic, predisposition, right, because of their disease. So just because their platelet count is low does not mean we can, pass on giving them anticoagulation. They need indicated anticoagulation as much or worse than any other patient with a venous thromboembolic event. So let's say we have a patient with ITP, their platelet count is well controlled on the therapy that they're on. Let's say it's a thrombopoietin receptor agonist, and they develop a major deep vein thrombosis or pulmonary embolism. I continue the thrombopoietin receptor agonist. I do not stop it because I want an adequate platelet count, even if the TPORA had a potential contributor to that VTE event. I will continue the thrombopoietin receptor agonist, and I will give anticoagulation as indicated to treat the VTE. If a patient is, has a low platelet count and they develop a VTE, then I will start whatever therapy I need to start to raise their platelet count such that they can safely be anticoagulated. You might say, what threshold is that? Okay, so it depends on the patient. If it's an 80-year-old patient with multiple comorbidities, you might need a high platelet count. You might need very clearly a platelet count above 50,000 for any sort of antithrombotic therapy, including single dose aspirin. A low dose aspirin. If you're dealing with a younger patient, a more typical patient, a patient that does not have multiple comorbidities, does not have increased risk of bleeding, is not on other drugs that can increase their risk of bleeding, the French group has looked at this. You can if for patients with ITP, platelet count of at least 20,000 is good enough for aspirin, a single dose antiplatelet, and a platelet count above 30,000 is generally good enough for anticoagulation, for therapeutic anticoagulation. So, you have to take into account the patient's risks for bleeding, but you have to treat the patient. And if it's from a thrombopoietin receptor agonist or maybe related to a thrombopoietin receptor agonist, people are scared and they want to stop the thrombopoietin receptor agonist because the patient had a clot. And no, continue the TPORA, treat with anticoagulation. After 3 to 6 months, if it was a provoked clot, you can decide whether you want to stop anticoagulation and stop the thrombopoietin receptor agonist. But in the acute setting, they need that anticoagulation. Otherwise, they're going to develop bad post-phlebitic syndrome in many cases.
Mhm. So if the cause of thrombosis is maybe due to the antiphospholipid syndrome, and I have a patient, and she's very difficult to manage, and she's stable with round about platelet count 100 with steroid and mycophenolate, but she got a recurrent DVT. So I prescribed warfarin, and she is now complicated with the atrial pulmonary TB pleural effusion.
Oh
So,
no.
yeah.
So
What's your
the pleural, you said the complicated they have a pleural effusion from a hemothorax from bleeding?
No, sir.
Oh,
No. Yeah.
it's just a standard pleural effusion.
Yeah.
Okay.
Pleural effusion. Yeah.
So I mean the patient's what's their platelet count?
Round 100, round about 100. She's stable with
100.
platelet count 100. Yeah.
Okay. Yeah, I mean, when was her last venous thromboembolic event?
More than 6 months. But she's on warfarin.
Is the question, can we do a thoracentesis to drain the pleural effusion while the patient's on warfarin, or what? I just want to.
Yes.
Okay, yeah. So I mean, in
I've
this circumstance,
changed to inoxaparin at the time.
sorry.
Change to inoxaparin.
Oh, change to
Inoxaparin.
enoxaparin. Okay,
Aspirin.
okay,
Yeah.
yeah.
At the time.
So what I would do, particularly if this patient had a high risk for bleeding, if the pleural effusion is enough, are they in the hospital? Are they admitted?
No, she's
No.
just from hospital.
Got it. Yeah, I mean, I think it's reasonable to essentially hold the enoxaparin 24 hours later, there's going to be very, very little enoxaparin left in the system. Do the procedure, drain the fluid, and then, approximately 48 hours post-procedure, restart the enoxaparin. I mean, she's going to be unprotected for a short period of time. Does she have antiphospholipid antibody syndrome or just?
Yeah.
Oh, okay.
Yes,
Sorry. I missed that. I missed that.
Yeah.
Okay. So if she has antiphospholipid antibody syndrome, I would admit her. I would switch the enoxaparin to heparin. I would, stop the heparin drip for the procedure and then restart it shortly. So bridge with a heparin drip, restart it shortly after the procedure. If she, especially is a triple positive antiphospholipid type patient, yeah, I'm very, very cautious in those circumstances.
Thank you.
Yeah.
Thank you. One more question from Dr. Lee Bi-sun. In cases of refractory ITP due to steroids, how do you choose between second-line rituximab versus TPO agonist?
Yeah. So I tend to discuss both options with the patient. So, my preference and most patients' preference is for a thrombopoietin receptor agonist, and we are able to access them for most patients in the U.S. Rituximab is a perfectly reasonable choice. I tend to favor rituximab in people that have secondary ITP with other autoimmune diseases, right? So if somebody has Sjogren's syndrome or they have lupus or some other autoimmune problem and we can treat both with the rituximab, right? I would be more in favor of that. If somebody has antiphospholipid antibodies, even if they don't have antiphospholipid antibody syndrome, I may be more apt to select rituximab over thrombopoietin receptor agonist. So it's really in that kind of circumstance. But in the typical primary ITP patient that doesn't have any of those complications, most people prefer a thrombopoietin receptor agonist, and that's usually my preference as well.
Thank you so much, sir, for clearing
My
all our
pleasure.
doubts. That was fantastic. We have taken a lot of time of yours.
No problem.
The half hours you're continuously speaking, not a single break. Thanks a lot. It was a
My
quite
pleasure.
experience. Wonderful lecture,
Thank you, sir.
fantastic lecture, and wonderful discussion. Thanks a lot.
Thanks to all.
Thank you,
Thank you
sir.
for the invitation.
Thank you so much. Thanks a lot. So, what should we do, Nikhil? Bye. What should we do? Yeah, he is joined.
Hello, hi,
Hello,
Dr.
how are you,
Khurana.
sir? Very good evening to you. Very good morning to you, and good evening. It was good evening for all of us here.
Good
So,
evening.
welcome. I just introduced you. Are you ready with your presentation, sir?
Yes, yeah, I have the PowerPoint ready, so I can share my screen whenever you want.
Just share my screen once again because we just had our first lecture over.
Okay.
So, well, friends, we have our second guest speaker ready now. He's Dr. Rajshekar Chakraborty from Colombia. And just to brief about the introduction of Dr. Rajshekar Chakraborty, Dr. Rajshekar Chakraborty is MD and Assistant Professor of Medicine at Columbia University, Irving Medical Center in the Division of Hematology Oncology. After receiving his medical degree from University of Delhi, India, he completed his residency in internal medicine at Ikahan School of Medicine at Mount Sinai Queen's Hospital Center. Subsequently, he spent 3 years as a clinical researcher in plasma cell disorders at the Mayo Clinic, Rochester, followed by fellowship in hematology oncology at the Cleveland Clinic. Dr. Chakraborty primarily cares for patients with plasma cell disorders, including multiple myeloma, amyloidosis, MGUS, POEM syndrome, and Waldenström macroglobulinemia. His research interests include clinical trials and outcomes research in plasma cell disorders. Today he's with us and he's going to lecture us on smoldering multiple myeloma. Well, thank you so much. I stop over here. Over to you, sir.
Thank you, Dr. Khurana, for the introduction. Let me share my screen. Just a second. can see my screen, right?
Perfect. Please go ahead, sir.
All right, let me minimize this. Okay. All right. So, yeah. So, I'm Raj. So today we will speak about how I manage smoldering myeloma. Now, this will, not be a very long talk. I'll go over all the trials. So it will take maybe about 35 to 40 minutes, and then maybe we can have like a 15-20 minutes of discussion. I think it would be fun to discuss like how you all are managing smoldering myeloma in India, and what do you think about the recent data from the Kila trial. So I'll just quickly go over the slides, to kind of summarize the data and how the practice is in the United States and Europe. So I'll start with the case. So this is the patient that I saw a few years ago in my clinic. So just briefly, 65-year-old male. My voice is okay, right? You can hear me okay?
Yeah, perfect, sir.
All right. So 65-year-old male with no medical history presented to his primary care doctor for his annual checkup. And he otherwise feels great, had no any other symptoms. And they did a routine CBC and complete metabolic profile that incidentally showed a total protein level of 9.4 with albumin of 4.0. So there was a significant protein gap on routine testing. Then the primary care doctor, based on that, sent workup including SPEP immunofixation light chain due to the elevated protein, and it came back as M spike of 2.6 grams per deciliter. It was IgG kappa and a kappa lambda ratio of about 25. A PET-CT was done to make sure that this was not myeloma, and the PET-CT did not have any lytic lesions or any focal lesions. And
Okay.
then a bone marrow biopsy was also performed, and it showed 11% plasma cells, so it was not more than 20%. And cytogenetics was hyper deployed. So as you can see here, just to summarize this case, this patient had an M spike of more than 2 grams per deciliter, had a kappa lambda ratio of more than 20. However, the bone marrow plasma cell was 11% and had a hyper deployed on fish, so did not have any of the high risk cytogenetic abnormalities. So the question is, what would be your recommendation for this patient? How would you manage this patient? And we'll come back to the case maybe at the end of the talk, after we go over some of the trials in this area. So I think some of the important questions here is, what is the diagnosis, for this patient? Where does this patient fit in based on the 2014 diagnostic criteria? What is the patient's risk of progressing to symptomatic myeloma? That's something patients are always curious about, when they have smoldering myeloma or MGUS. And then finally, should we be recommending any treatment, or should we be just watching them, on active surveillance over time? So I'll just recap the IMWG diagnostic criteria for myeloma. I'm sure you guys already are very much aware of that. So as you know, this is a continuum from MGUS to smoldering myeloma to multiple myeloma. And the definition of smoldering myeloma is an M protein of more than 3 grams per deciliter, or more than 500 milligram of Benz-Jones protein in the urine. Or along with that, the clonal plasma cells has to be about 10 to 59%, because if it's more than 60% as per the current criteria, it becomes myeloma, and the patient should not have any slim crab. So I think this is a very important part of the discussion here, that the modern smoldering myeloma does not, it excludes the slim patients. Whereas if you look at any smoldering myeloma publication before 2014, those slim patients were at that time called a smoldering myeloma. So a lot of the data on progression of smoldering myeloma to myeloma basically comes from the pre 2014 era, when the slim was still a part of smoldering myeloma. And now that slim has been taken out from smoldering myeloma and is considered as real, like symptomatic myeloma. That's the reason that smoldering myeloma has somewhat changed over the years. The really ultra high risk patients have been removed from the smoldering myeloma category. And also another important thing here is, because the slim includes MRI, so there has been a lot of data in the past few years that a whole body diffusion weighted MRI is more sensitive than a PET-CT for identifying tumor burden at baseline in smoldering myeloma and in newly diagnosed myeloma. So basically, before securing a diagnosis of smoldering myeloma, it's very, very important that the patient gets a whole body diffusion weighted MRI if that is available in the center. If that is not available, I think PET CT is a reasonable alternative, although PET CT is slightly less sensitive. So we can miss about 10 to 20% of lesions on PET CT, which we can detect only on whole body diffusion weighted MRI. So here I would like to point out, if we go back to this case, that this patient did not have a whole body diffusion weighted MRI performed, had only a PET CT performed. So just a second, I'm sorry. So I think that's an important part of the discussion here that we will go over a little bit in some of the trials. That whole body diffusion weighted MRI is not being performed routinely as baseline workup in most of the trials. And at the end in the discussion, I would love to hear your practice in India. I know when I discuss with some of my colleagues in India, they say that in many centers it's actually available whole body MRI, which is great. But we can certainly discuss about that at the end. So one thing I wanted to point out here, the SLIM criteria, although in 2014 it was kind of included within myeloma, but over time we have seen that the risk of progression of SLIM, especially in the patients with free light chain ratio of more than 100, is not as high as we initially thought. So if you can see in the initial two publications, which primarily informed the IMWG diagnostic criteria, which is the Castretis et al. And the Larson et al., you can see if patients who had free light chain ratio of more than 100, their risk of progression at 2 years was very, very high. It was, close to about 80 to 98% approximately. But you can see the subsequent publications have shown that maybe it's not as high as we had initially thought, especially if you, look at this diagnostic criteria, by Wu et al. This paper by Wu et al., which was published on the Mount Sinai group in 2018, and it was a very, very large study. And in that study, it did show that the risk of progression is, of risk of progression to myeloma at 2 years, which is basically the red. If you look at the red dot here, it was roughly about 50%. So it was not as high, and that's why now, in most centers in the US, if that is the only SLIM criteria the patients are meeting, we don't always treat them. We sometimes watch them. We look at the 24-hour urine, to look at how much Benz-Jones proteins they have, and if that is low, sometimes we don't always treat these patients. So this is a seminal study by Dr. Rajkumar and Dr. Kyle from Mayo Clinic, which really taught us a lot about smoldering myeloma, its natural history, and kind of defined the natural history of smoldering myeloma. And you can see here that in the first 5 years, the risk of progression from smoldering myeloma to myeloma is roughly about 10% per year. After that, from 5 to 10 years, it decreases to about 3% per year. And subsequently, it's almost parallel to the MGUS curve. So subsequently, it almost becomes about 1% per year. So this, 50% risk of progression at 5 year in all comers with smoldering myeloma, that is something that was defined, in this seminal study. But one has to keep in mind that this was before the slim crab era, and also at a time when the baseline imaging used to be skeletal survey and not advanced imaging. So, you can reasonably argue that some of the patients, in the smoldering myeloma curve here would now be classified as myeloma. And we see that now that, now even in, like, if you look at the high risk smoldering myeloma category, that particular category, the risk of progression at 5 years is roughly, in the ballpark of, more 60-70%. But in all comers, it's much lower. So things have changed over the years. But this is one of the seminal papers that kind of helped us in identifying the natural history of smoldering myeloma in the 1980s and 1990s. Then there are advances in imaging and diagnostic reclassification, as I had said, had changed the natural history of smoldering myeloma. So initially, we used to do only skeletal survey or X-ray, and then subsequently PET CT. And then, as early as 2004, a whole body diffusion weighted MRI was proposed as a novel technique for identifying focal lesions and basically to identify myeloma early. And then in 2014, of course, diagnosis was changed. And now, today plasma cells of more than 10% in the marrow and normal X-ray, often gets upstaged if whole body MRI or a PET CT is done, and if there are lesions, then they will sometimes get upstaged to multiple myeloma, for example. So it's very, very important whenever we look at any publication of smoldering myeloma to make sure that appropriate baseline imaging has been done to secure a diagnosis before calling it smoldering myeloma. So there are several risk stratification models which are available for smoldering myeloma. They are kind of discordant with each other. The one that is, I would say, the most helpful is the Mayo 2018 model. This was published by Dr. Arjun Lakshman et al. From Mayo Clinic. I think the last author was Dr. Rajkumar. So that is the one that we are currently using in clinic in the US. It's not perfect, but still, I think it's better than the others because this is kind of the only model which is not outdated. So the other model, the Pathima model and the Mayo 2008 model, these models, included patients before the 2014 era. So basically, they included patients in whom only a skeletal survey was done at baseline. But the Mayo 2018 model included patients in whom uniformly the patients got at least a whole body CT, if not a PET CT or a whole body MRI. So the Mayo 2018 model, I think, is the most up to date model, although it's not perfect, but that's the one that we use mostly. And the high risk versus non high risk is discordant in all of these models. They don't agree with each other, obviously, because of the different patient populations that went into these models. So now I'll focus on some of the key trials, for smoldering myeloma. I'll go over them, with the kind of the take-home message and also the shortcomings of each trial, and that will help us, inform at the end that what should we do for our patient. So this is kind of one of the oldest trials, but well done phase 3 randomized trial, for that time in high-risk smoldering myeloma. So they used the Spanish criteria, the PETHEMA criteria, and patients were randomized to Lendex versus observation. And you can see there was a big progression-free survival benefit of Lendex versus observation. And there was also an overall survival benefit as well. Starting about 10 months, the overall survival curve started splitting, in the treatment arm versus the observation arm. So I think this was a very, provocative findings at that time, because at that time in 2010 or 2015, nobody was really thinking about even treating smoldering myeloma in the real world, and this trial came out, and it definitely raised a lot of discussion. Now, although this trial at that time, for that time it was well done and the findings definitely are robust, especially the PFS finding, but there are a couple of things for which this trial was never really, I would say, was able to translate into clinical practice. There were a couple of key fatal flaws or shortcomings, as things changed over time. So what are the problems here? So first is no advanced imaging was performed. And if you go back, if you see the progression-free survival curve of the control arm, there is a rapid drop in the progression-free survival curve in the control arm, which is almost similar to a myeloma trial. So that, very typically this kind of rapid drop in the PFS curve, it tells us that there were some patients who were likely occult myeloma, who were kind of, I would say, misdiagnosed as smoldering myeloma because only a skeletal survey was done, and unfortunately, those patients, some of those patients were randomized to observation, and those are the patients who probably, dropped off right away. And this was something that FDA also noted recently when they discussed the Aquila trial, that why the Pathema germ or the Queredex trial does not really apply to our current clinical practice. Then the control arm was not given len upon progression. So if you go back, so whenever you're doing a randomized trial in an asymptomatic condition, so for example, if you're doing a randomized control trial in MBL or monoclonal B cell lymphocytosis, one of them was done in the US, ibrutinib versus placebo in MBL. You have to make sure that when patients are then progressing to CLL in the control arm, they get an appropriate treatment. Either they get, ibrutinib-based treatment or, venetoclax-based treatment, some kind of contemporary treatment. And if they don't get that, then, you're kind of asking a question of ibrutinib at the MBL stage versus ibrutinib never, which is not the question that we are interested in. We are interested in whether in the control arm, if when they progress, they should be getting contemporary treatment, at least reasonable contemporary treatment which is acceptable across the globe. So that's, I think, was a key fatal flaw here, because at that time VRD was slowly being recognized as the standard of care for the frontline treatment of multiple myeloma. And even when this trial was ongoing, there was already data that Revlimid dexamethasone, would be an appropriate, reasonable standard of care frontline treatment for myeloma. And these patients did not even get Revlimid. Many of them got melphalan-based treatment or, VMP, bortezomib, melphalan, dexamethasone. So that was a big problem with this study, because of which we can't really, interpret much from the overall survival curve here. Then the trial was not powered for overall survival, and it was, the results could definitely be spurious given the small number. Then there were diagnostic changes in 2014, which I had already went over, and it further affects the applicability of the result, today. And the model that they use, the PETHIMA model, is not the one that we are using anymore much in the United States. So we don't know how that even applies in the current day and age. Given the PETHIMA model was designed in 2004, so it's a very, very old model, and in very different patient population. So because of all these problems, I think Queredex trial never really penetrated clinical practice, either in US, Europe, or UK. And, it's almost, I would say, especially the US, until the ECOG trial came about, which I'll show you in a couple of slides, the use of Revlimid in smoldering myeloma, even high risk smoldering myeloma, was almost negligible. Then the next trial, this was a better trial, which was the phase 3 trial for smoldering myeloma, the E3AO6 trial. This was led by Dr. Sagar Lonial and Dr. Rajkumar in ECOG. So here, smoldering myeloma, initially it was designed to be a trial of only high risk smoldering myeloma, but then because of slow accrual, they included, all comers, all with smoldering myeloma, and they were randomized to Revlimid versus placebo. In this trial, overall, they did see a PFS benefit, but that PFS benefit was mostly driven by the Mayo 2080 high risk group, as you can see here. But there was no overall survival benefit at roughly about, I think, 4 years of follow-up. We have not seen any update on this data yet. Now, this trial was better in the sense that every patient got reasonable baseline imaging. They got a MRI of the spine and pelvis as well. So although not a whole body diffusion, we had MRI, which is the gold standard, but at least they got reasonable imaging that we can say that this trial unlikely had a lot of, occult myeloma, introduced in the trial. And you can see that in the PFS curve, that the PFS curve is not really dropping sharply in the observation arm. It takes a while for it to slowly drop off. And that's also mostly in the high risk group. In the standard or intermediate risk group, there was not even a clear signal for the PFS. So this was not, I don't think this was a registrational trial. This trial never led to FDA approval. But based on this trial, I would say that in the US, not all high-risk smoldering myeloma, but some high-risk smoldering myeloma patients, we, on a case-by-case basis, we have been using Revlimid, for a limited duration, like about 2 years. But again, after discussing with the patient that there is no overall survival benefit, there is a small risk of secondary cancers. So it's very rare. In my practice, I would say I have used very minimally. My standard of care still remained observation. But I've definitely seen some clinicians using Revlimid, in less than 10% of their high-risk smoldering myeloma patients. So based on this data, the conclusion of the authors was that high-risk smoldering myeloma should be treated, or at least should be considered for Revlimid. But you can see here that the number of patients here were too few to reasonably conclude anything here. So there was a lot of controversy around this. I'm sure you guys, many of you have seen on Twitter as well, a lot of robust discussions going on in high-risk smoldering myeloma. And there is one camp who thinks it should not be treated, one camp who thinks it should be treated. It's kind of a judgment call. I think based on this data, I don't think one can make a strong recommendation that high-risk smoldering myeloma should be treated with Revlimid. And appropriately, in NCCN guideline, all three options are given as reasonable, including observation with active surveillance, Revlimid, and clinical trials. Now, whenever another important thing that you got to look at the smoldering myeloma trials is what kind of progression events are you preventing? And thankfully, in the ECOG trial, they did give us that data. So if you can see, the kind of progression events that you're preventing are mostly anemia, so about 8 patients with anemia in the observation arm, 12 and 4 in the Revlimid arm. So renal failure was very, very few. So overall, only about 3 patients got renal failure. And you did prevent bone lesion or soft tissue plasmacytoma, although these events were all asymptomatic. So none of them were really fractures. So most of them were asymptomatic, that was picked up on a PET CT, for example. So basically, overall, you mostly prevented asymptomatic or non-morbid events. You did not really prevent a lot of morbid progression events. Then there were some trials, including the GEM Caesar and the ASCENT trial, which were single arm, not randomized trials, including a very, very intensive regimen. I must say that these, intensive regimens really give me a heart attack when I see these trial designs, because this is an asymptomatic patient population. I personally would not feel comfortable enrolling my high-risk smoldering myeloma patients on a trial like this when they're otherwise, completely asymptomatic. including things like KRD followed by transplant followed by consolidation. And despite such an intensive regimen, only about 23% of patients sustained MRD negativity in this trial after 4 years of follow-up. So if a patient, is really considering getting treated to delay progression to myeloma, I would use something gentler, like Revlimid, for example, or we'll go over the Aquila trial a little bit, daratumumab. But I personally think that there is definitely a risk of harm with such an intensive approach. And until there is a randomized trial showing that this is better than doing nothing or a more gentle approach like Revlimid, I think we cannot really justify subjecting our patients to an aggressive approach like this. And although the authors said the safety profile was acceptable, there were 4 deaths that were reported potentially due to treatment in this trial, including cardiac arrest, and ischemic stroke. And there were other notable toxicities because of carfilzomib, including heart failure, AFib, etc. Then there was the Ascent trial, which was a DARA KRD, and it did not include transplant. So, it was 6 cycles of DARA KRD induction, then consolidation, and then 12 cycles of DARA and maintenance. Even this trial, if you look at the stringent complete response rate, which was the primary endpoint, was only about 38%. The primary hypothesis was that it would be at least 65%. So the trial, unfortunately, failed to meet its primary endpoint. And although it's not as aggressive as the GEM-CSAR approach, but still, carfilzomib can cause, as you all know, cardiac failure, atrial fibrillation, pulmonary hypertension, and subjecting an asymptomatic patient who has, let's say, a 50% chance of not progressing to myeloma in the next 4 or 5 years, to this kind of treatment, I don't think is justifiable until there is a randomized trial showing that it improves quality of life or overall survival. So we did a survey in the US. It was actually not only in the US. I think it was an online survey, so others could also have done it. That was published a couple of years ago with some of my colleagues. And we looked at the clinician preferences on treating smoldering myeloma. And this was before the Aquila trial came about. And as you can see here, as far as high risk smoldering multiple myeloma is concerned, 92% of clinicians still prefer doing active surveillance. Only 6% of clinicians thought that they would do Revlimid dexamethasone, and 2% were other. And even when we looked at the slim myeloma or slim criteria, about 37% still chose to do active surveillance, and about 60% would do a myeloma-like treatment, and only 3% they picked lenalidomide, treatment similar to a smoldering myeloma approach. So you can see this, at least in smoldering myeloma, majority of clinicians up until recently were doing active surveillance even in the US. There are a lot of single arm trials. I won't go into that in detail, including a single arm trial of teclistamab. Then there is a single arm trial of CAR-T, for example. Again, these are very, very early data, and the claim is that they, at some point, it's possible that they might lead to cure in a small subset of patients with very high risk smoldering myeloma. I think it remains to be seen with long-term follow-up. But with the toxicities of bispecifics and CAR-T, again, it's very, very early. I don't think it's ready for prime time yet, and we really need to see long-term data to make sure that we are not harming our patients, before adopting these therapies in clinical practice. We have a trial ongoing. It's being led by the University of Utah at Huntsman, and Columbia. We are also participating. It's an observation trial. So here we are enrolling patients with high risk smoldering myeloma. Our goal is to enroll 100 patients. So far, we have about 20 patients accrued already. And then they will basically get active surveillance with labs monthly for the first year, and then every 2 months for year 2. We will do yearly bone marrow biopsy. We have amended that to do yearly bone marrow biopsy only if there is rising numbers. And we are doing a whole body diffusion variant MRI every 6 months for about 2 years. So it's quite an intensive active surveillance. And our primary endpoint here is the rate of morbid progression events. So, any morbid progression events like renal failure, for example, will count as a primary endpoint. And our hypothesis is that the rate of morbid progression events at 2 years will be less than 10%. And if it's more than 10%, then that will mean that our hypothesis was false, and it would not be safe to actively surveil these patients. So it's ongoing. We will hopefully be able to generate some preliminary data at next year or the year after, once we have at least 30 or 40 patients to look at the rate of morbid progression events. So far, we have not had a single morbid progression event. A couple of patients have progressed just with slim criteria, so asymptomatic progression, and they went on to receive myeloma treatment. Then this is the Aquila trial that was recently presented at ASH, and was also a simultaneous publication on NEJM. And I'm sure you guys saw recently there was an FDA Oncology Drug Advisory Committee on this trial as well. And in this trial, patients were randomized to daratumumab versus observation. And this trial did have good baseline imaging, although not a whole body diffusion weighted MRI, but they had at least a whole body CT or a PET CT. The investigators did not really disclose what percentage of patients got a PET CT, because we know that whole body CT is less sensitive than both PET CT and whole body MRI, but 100% got at least a whole body CT. And also, they were also supposed to get MRI of the spine and pelvis, so not a whole body MRI, but they had reasonably good imaging. And there was definitely a significant progression-free survival benefit. And also, although the overall survival benefit is not like technically statistically significant yet, but you can see a trend. However, there are a few caveats here which I will mention. So first of all, the primary endpoint was progression to slim crab. So it was not only progression to crab myeloma, it was progression to slim crab. And one can argue that are the slim events really clinically meaningful, because we don't really know whether whether the risk of the slim events progressing into crab events is 80%, as was initially thought. Maybe it's slightly lower. And the reason we start treating patients at slim is because we want to prevent end organ damage. So, using slim events as kind of the PFS events in this trial, that was definitely frowned upon even by the FDA in the recent discussion. So there are a few issues here. So first of all is subpar imaging compared to current standard. The trial used spine, pelvis MRI rather than a whole body MRI. Up to 50% of lesions present in long bones can be missed. We know that from several studies done in UK and Germany on whole body MRI. The protocol recommended low dose CT. So PET CT was not universally used, and imaging was done only once a year. And patients who are really high risk smoldering myeloma with rising numbers sometime, in those patients, once a year may not be enough, because we may miss an evolving focal lesion, and we might have to do it a little bit more frequently, like every 6 months, especially in those with evolving numbers like light chains or M spike. Then, the second issue is that daratumumab prevents asymptomatic lab and imaging changes. So we saw that in the trial, in the control arm, which was the active surveillance arm, there were zero fractures, there were zero renal failure. So I think that's a very important information to share with the patient if they're contemplating using daratumumab, that by closely watching them, the chances that they are one day suddenly going to be present coming in once a year, then it's possible that they may present with those events. And if we are following them, we have to really follow them very, very closely. And there was also 5 occurrences of more than 60% plasma cells in daratumumab versus 16 in the control. A lot of the PFS events were driven by anemia, but FDA recently showed us the data that the average change in hemoglobin was 1.7 gram per deciliter. So you can argue that whether that's really a meaningful change, because 1.7 gram per deciliter, it's a very, very low level. So I don't think personally it's a very, very meaningful change in hemoglobin. And then, none of the patients required transfusion. There were no fatigue or anything like that, no symptoms. And all the bone diseases that were seen, they were predominantly captured on imaging, either a whole body MRI or PET CT. There were no fractures. So I think it's a very important discussion to be had with the patients. And, after I have this discussion with the patient, a couple of my patients will say that they even want to prevent those asymptomatic events, because diagnosed with myeloma basically means they have to go on Dara VRD and then transplant. So they would want to delay that. And I think that's reasonable then to treat them with Dara. But I think definitely we need to discuss that with patients, because some patients after listening to this would rather, be observed closely, as long as, they are reassured that it's very unlikely that they will present with fractures or renal failure if they follow closely with us. Then the overall survival signal is very, very hard to interpret here, because similar to the Spanish trial, when patients got myeloma, they received subpar treatment. So, a very few, like less than 20% of patients received daratumumab as part of first line treatment. Only about 29% received VRD. And I calculated the regimens, in the supplementary appendix, and about 50% of patients got something other than VRD or a CD38 based regimen. So many of the patients got doublet, for example, or even single agent which is not the standard of care for newly diagnosed myeloma. So they really should have control for that. And because of that, it's very hard to know whether the overall survival trend that we are seeing would still hold in the current era when a patient would be getting DARA VRD for frontline treatment. And that's why, as I say, the overall survival results are unreliable. So the another issue here is that some can argue that if you are in the daratumumab arm, you are getting the myeloma treatment later compared to when you are in the active treatment arm. But if you look at the curves here, that's true that patients in the daratumumab, for example, at 3 years, only 20% of these patients had received second line treatment, and whereas in active monitoring arm, it's already about 40%. But if you go forward, if you look at 5 years, for example, there is still about 40% of patients in the active surveillance arm who have not received any treatment. So those 40% of patients you would be over treating by treating everybody with DARA in the beginning. So I think that's a very, very important thing to keep in mind that at about 5 years, about 40% of patients in the active surveillance arm still did not need any treatment, and those patients basically would be over treated if you're treating everybody with daratumumab. And of course, the risk of grade 3-4 infection was higher, was about 16% in DARA arm versus 4.6% in the control arm. And it might even be more in some developing countries, for example, where the risk of infection is higher. And these are asymptomatic patients. So how do I counsel patients, right now after the Aquila trial? So basically, I tell patients that daratumumab will definitely improve the asymptomatic lab and imaging findings. It will prevent, rather than improve, I should say prevent or delay. I would not say prevent because it's not curative, but it would delay asymptomatic labs and imaging findings. Their observation strategy in the trial was not as good as we would do currently in the US, with the whole body diffusion where an MRI every 6 months. And then patients in this trial also did not get as good therapy as we would get if patients developed myeloma now. And although the patients who got daratumumab lived slightly longer, that result is unreliable, and I don't think it really applies to the current day and age. And of course, daratumumab will increase the risk of infection by about 3 to 4 times, and that definitely severe infection can lead to hospitalization. So I usually have this discussion with patients, and I would say about 70 to 80% of my patients are still choosing active surveillance. 20 to 30% they are taking their chance to get daratumumab. One thing though is that daratumumab overall, other than the infection risk, is fairly well tolerated. Does not really have any symptomatic adverse events, so that's definitely a plus. And also does not have any late toxicities like secondary malignancies, like Revlimid. So that's also an important thing to keep in mind. All right, so these are the conclusions. So before I go to the conclusions, I wanted to go back to the case again. So if we go back to the case that we discussed initially, so this patient basically, based on the Mayo 2018 model, would be considered as a high-risk smoldering myeloma because the patient has 2 out of 3 high-risk abnormalities, an M spike of more than 2, and a kappa lambda ratio of more than 20. So that's number one. The second is this patient only had a PET CT, so I would definitely try to do a whole body diffusion with an MRI if available to make sure that the patient does not have any focal lesion that would upgrade these patients to multiple myeloma, and then I would treat them as multiple myeloma. And assuming the whole body diffusion weighted MRI is negative, then I would, discuss or counsel the patient as I had said, and will basically make a shared decision. And if the patient leaves the decision completely up to me, then I would recommend that we would just monitor them with whole body MRI every 6 months for at least 2 to 3 years, because that's the time, the first 2 to 3 years from diagnosis, when risk of progression is the highest. And I would still continue to surveil them closely and not treat with daratumumab. With that, I would end, and I'm happy to take any questions and discuss as to how your strategies in India to manage these patients and how do you follow these patients if you're not treating them.
Thank you, Dr. Raj. Wonderful lecture. Fantastic. I request all our discussants to please put the hand raise signs so that we can have this question answer session with Dr. Raj Chakraborty.
And if anybody has any question in the chat, I'm happy to answer that as well.
Just wait for some time. Let the questions come. So before any questions come, I have a question for you. Yeah, you have a question, Dr. Nee?
No, sir, not yet, sir.
So I have a question for you. In your practice, if a patient is high-risk smoldering myeloma, do you recommend treatment?
In our practice, if the patient leaves it up to me, ask what my recommendation would be, then I would just as long as I know, as long as I think the patient is going to be reliable in following up, I would not recommend treatment. I would just recommend observation, close observation, with every 6 month imaging. I think the main thing that we worry about when we observe them is that we don't want them to present one day with fracture or pain, because that would be, I think, that we could have prevented or delayed by giving daratumumab, right? So if I'm observing them, typically I would follow them very, very closely and the main thing would be to do this whole body MRI every 6 months for the first 2 or 3 years, because whole body MRI can catch those focal lesions before they evolve into lytic lesions or fracture. So that's what I would do. Now, if the patient really wants to get the data for 3 years to delay their risk of progression, I would be fine with that if the patient wants that. But I would not recommend it if they leave it up to me.
And there is a case, sir. There is a patient, 32 years male, who
Hmm.
presented solitary plasmacytoma of D8 vertebra.
Okay.
Bone marrow was absolutely negative for any plasma cells. There was no M band. A
Mhm.
slight increase in the lambda light chain on kappa lambda analysis. No M band. Serum immunofixation was also negative. Only solitary bone plasmacytoma with lambda of 38, kappa of 25, and no bone marrow biopsy doesn't show anything, any clonal plasma cells in the bone marrow biopsy. The patient was given 45 gray of radiotherapy,
Mhm.
and patient is doing very well. After
Mhm.
about 2 years, now he
Mhm.
presents with multiple lytic lesions.
Mhm.
The M protein is negative, immunofixation is negative. The serum free light chain shows now lambda of 85. Bone marrow biopsy does not reveal any clonal plasma cells. There is no hypercalcemia. There is no high creatinine. Hemoglobin is normal and no M protein. Uh, Even immunofixation does not detect any M protein, but the PET scan shows multiple lytic lesions at D8 vertebra, D7, D5, and D4. What
Mhm.
your next line of treatment? The patient is 35 years of age.
Yeah, so this we see, I had a few patients like that as well. So with solitary plasmacytoma, I think the risk of progression from solitary plasmacytoma to myeloma is much higher than the risk of progression from, let's say, high-risk smoldering myeloma to myeloma. And there was a recent paper from the Mayo Clinic group, I think, which showed that, about 10 at 8 or 10 years, about 60% of patients, can progress to myeloma. So this patient has progressed to, kind of macrofocal myeloma, which has been definitely described, where you have the bone marrow is negative, but the patient just has multiple focus of these lytic lesions throughout the body. I would just treat that as myeloma. I would just treat that as dara VRD followed by transplant, as long as I would just do a biopsy, another biopsy in one of the FDG-IVID lesions to make sure that we are not missing a different cancer, which it doesn't look like we are, given that the lambda light chain also has gone up, and if it looks typical for myeloma. But yeah, then I would just treat as myeloma, even though the bone marrow is negative, because we can follow this patient with the lambda light chain and also with PET CT. PET CT did show a high SUV, right? So we can follow after treatment.
Thank you so much, sir. A question has come from Dr. Narendra Gemawat. How often we do PET scan in smoldering myelomas?
So PET scan, in the US, most insurances will cover PET scan only like once a year. So sometimes it's hard to do more frequently than that for observation. If of course something new, then they will cover it. So I, in my practice, only do whole body MRI for smoldering myeloma. I don't tend to do PET scan just because I don't want to expose them to so much radiation if I'm doing it every 6 months. So and whole body MRI for some reason it tends to be covered more by insurance here. So I usually do whole body MRI, but if I were doing a PET scan, I would do it at least once a year. But if the numbers are rising, the M spike is rising or things like that, then I would probably want to do it every 6 months if I can. But my practice in smoldering myeloma is just to do whole body MRI because it's more sensitive than PET CT.
Perfect. Thank you, sir. Another question from Dr. Sui Louis 10. How would you treat patients with solitary plasmacytoma with smoldering multiple myeloma?
Oh, so if somebody, yeah, that's a good question. So if somebody has solitary plasmacytoma, but let's say the bone marrow has more than 10% plasma cell, then that's kind of a, that's a little bit of a gray zone. So if the bone marrow has 30 or 40% plasma cell, then I would probably just go ahead and treat as myeloma. But I think the problem happens when it's like 15% or 10% plasma cell. In that situation, do you really want to treat as myeloma versus, just radiate that area and follow the patient closely? I think in that situation, I usually have a discussion with the patients and, we decide together most of the time if it's below 20%. So if it's smoldering myeloma, but the bone marrow plasma cell is not like 30 or 40% and there is only one lesion, I would just radiate the lesion and watch the patient very closely with every 6-month whole body MRI. But if it's more than 20% plasma cell in the bone marrow, then I would just go ahead and treat as myeloma.
Thank you, sir.
But yeah, in up by the way, in up to date, Dr. Vincent Rajkumar has the chapter on smoldering myeloma where he discusses in a few paragraphs this, and even there are a few citations there which I think are very helpful as well. And he kind of discusses this topic that this 10 to 20% is kind of a gray zone, and it's very hard to like make a decision because there is not much data for that particular area for the 10 to 20, 15%, the gray zone between smoldering myeloma and real myeloma.
Thank you, sir. Another question from Dr. Libby Sun. By definition, smoldering multiple myeloma has no SLIM criteria and no CRAP criteria. But if the patient has got hemoglobin of 11 and is totally asymptomatic with a eGFR of 60, is it considered smoldering multiple myeloma or multiple myeloma if your M protein is 45 grams, no lytic lesion?
So if the hemoglobin is 11, so the IMWG criteria for myeloma is that the hemoglobin has to be either less than 10 or has to be less than 2, compared to that lab limit of, normal. So, it depends. So it's definitely 11, so it's not less than 10. So I would just go back and see what the patient's baseline hemoglobin was. So let's say if 2 years ago or 1 year ago, the patient's hemoglobin used to be 14 or something, and now it's 11, then I would be worried that yes, this patient hemoglobin is going down. Whereas if the patient's baseline hemoglobin has always been about 11 to 12, for many, many years, then I would not say that this is myeloma. I would just watch them as smoldering myeloma. So I would just compare that with the patient's own baseline of a couple of years ago and see if there is a drop. Because if it's only anemia, there is no rush to treat like right away. So you can, just watch the patient for some time to see the trajectory of it. If the hemoglobin is dropping, then yeah, that's definitely concerning. But if the hemoglobin has been 11 for 5 years, 6 years, then I would not be worried. I even have watched some patients with the hemoglobin of like 10.1 or 10.2 for many years, and patient is completely asymptomatic. And even though they meet the criteria for myeloma, I have just watched them.
Thank you, sir. Another question from Dr. Krishnathan Kannan. How do you interpret follow-up PET CT scan? What do you actually look for?
Yeah, that's a good question. So in smoldering myeloma, I'm assuming that the baseline PET CT scan was negative for any FDG avid lesion. So in the follow-up PET CT scan, I'm looking for appearance of any new FDG avid lytic lesion. So that's what I'm looking for. In whole body MRI, what I'm looking for is appearance of any new focal lesion. So the way radiologists are able to tell whether it's an active focal lesion or not is based on the ADC, the apparent diffusion coefficient, which, I'm not a radiologist, I don't know the details of how they do it, but in our tumor boards, we see that radiologists will look at the ADC, and if it's a low ADC, then those are concerning for active myeloma lesion. Whereas if it's a high ADC, then that's usually a healthy bone marrow. So based on the ADC, they will tell us whether it's an active focal lesion or not. So that's what we will be looking at.
Thank you, sir. There is one more question. A 45 years male who comes to you with a back pain. PET CT scan does not reveal any lytic lesion. The patient had undergone CT scan before also. There was no lytic lesion, and now he was undergone PET CT, again no lytic lesion. M protein was 1.5 grams. Bone marrow shows 18% plasma cells. Hemoglobin is normal. Calcium is normal. Creatinine is normal. PET CT scan, no lytic lesion. But when doing an MRI scan, there was only one focal lesion. Would you correct to consider this as myeloma or a smoldering myeloma?
It's a difficult question. Yeah, whenever there is one focal lesion, it's always difficult. So, if the pain is at the side where the patient has focal lesion, then I would be worried because that area probably is at risk of pathologic fracture, right? If there is an active focal lesion. In these situations, what I would do is there is no data because those with one focal lesion are typically excluded from all the myeloma trials, right? Because they don't fit the criteria for myeloma. And most actually smoldering trials also, I think, do not allow one focal lesion. Many of them, not all of them, but I think many of them don't allow. So I had a similar patient a couple of years ago, and what I did for that patient was I just radiated that focal lesion. And then I've been watching the patient so far. The patient hasn't progressed, but I would just consider that like a solitary plasmacytoma. And if the patient was if I would definitely discuss with the radiologist and in a tumor board. If we think that the pain has nothing to do with that lesion, the pain is in a different area, then I think we can just watch it closely. One thing that was shown from in Germany is that they did a prospective study, and when you have the single focal lesion, if there is increase in size of the focal lesion over time, that's usually a risk factor that it will eventually get like a compression fracture or something like that. It will evolve into a lytic lesion. So if the patient is completely asymptomatic at that area, I will follow closely with serial whole body, like serial spine MRIs. We don't have to do whole body. But if the patient is symptomatic, then I think we should just go ahead and radiate that area, just as a solitary plasmacytoma.
Thank you, sir. Dr. Ninmay Thanda, your question.
Thank you for your lecture, sir. I have a question about the diagnosis. As we are from resource limited area, we have when should we consider should we decide to do urinary electrophoresis when we did not find any other source, any other clues of myeloma in serum IFE or free light chain?
So, it's very unlikely that if serum electrophoresis and free light chain are negative, that you will find something on the urine, because in the urine, sometimes free light chain, that will basically filter in the urine. So, yeah, I would say that we typically do it here as a regular panel, but if both the serum and the free light chain is negative, then I think the yield is going to be very, very low, of doing a urine protein electrophoresis. Because so urine is actually will be in the new IMWG guideline that will be published, I think, soon. The urine testing is going to be de-emphasized. It's not that we don't need urine at all. We definitely need, it helps in diagnosis of other conditions like amyloidosis if there is albuminuria and things like
Yeah.
that. But doing the serial urine testing for even response assessment is kind of unnecessary in myeloma, it seems like, in the era of free light chain, because we can, follow the free light chain in the blood.
Thank you, sir.
Any other question, Dr. Ninmay Thanda? Fine. Thank you.
Thank you, sir.
So there's one more question. There is a patient who is just 25 years of age who presented with, actually was asymptomatic, but a routine analysis found somebody did a serum protein electrophoresis, and there was a 2.1 grams of M protein, which was seen in 27 years old male. The bone marrow showed 25% plasma cells. The CRAB features are negative. There is from the slim criteria is not matching with multiple myeloma, but FISH study shows translocation 11-14. Would you like to call this as myeloma, number one? Number two, should we start straight away on venetoclax?
Okay, so just to recap, so basically the M spike was 2.1,
0.1.
and then and bone marrow was how much? What percentage?
28% plasma cells.
28%. And the free light chain ratio? Sorry, I missed that. Did they say?
Mentioned actually.
But that's okay. And then no slim crab criteria, right? No anemia,
Yeah.
no slim crab, right? Yeah. So I would call this a smoldering myeloma. I would not call it as myeloma because the patient does not really meet any slim crab criteria. I would not give venetoclax because there is no data of venetoclax in smoldering myeloma. I would just monitor this patient, closely, with just like I would do any other smoldering myeloma. There was one trial on venetoclax and smoldering myeloma that was going to be open, but I don't think it's going to go ahead. So there is actually no data of venetoclax in smoldering myeloma at all.
Thank you, sir. Another question from Dr. Sundar. In patients with high-risk smoldering myeloma undergoing treatment, how do you integrate MRD monitoring into your decision making? Do you test by NGF flow or NGS or any other technique?
So
Also,
if
do you use MRD status to guide treatment duration or de-escalation?
No, so in high-risk smoldering myeloma, when we are treating, in the US these days, if we are treating at all, we are either using single-agent Revlimid or single-agent Dara. And the chances of achieving MRD negativity with those treatments is almost close to zero. It's very, very unlikely that patients will achieve MRD negativity with single-agent Revlimid or Dara. So I typically don't even check it, unless they are in a trial and they are, for example, we have a trial of the DETER SMM trial where the patients get randomized to Revlimid Dex versus Dara Revlimid Dex. So in the Dara Revlimid Dex, we have seen a couple of patients who achieved MRD negativity. So we are checking it. But no, there is no data to kind of do MRD guided treatment in smoldering myeloma. And the current treatments that we are using, they don't even lead to MRD negativity. So I wouldn't, if I'm treating, I would just follow with the blood work. I would not repeat, MRD.
And how do you do MRD if you're doing that? NGF flow or NGS or any
In
other?
US, slowly we are doing more and more NGS because the adaptive clonoSEQ test here is FDA approved now. So, but NGF is totally fine too. If your pathologist has good experience in NGF for myeloma, it's totally fine too. But we in the US we do mostly NGS these days.
Thank you, sir. There's one question from Dr. C. Louis 10. In a case of plasmacytoma or a multiple myeloma with a lesion in the bony lesion, when you go for irradiation, what do you expect the value of SUV max after the irradiation?
Yeah, it depends on what it was before, how high it was before. It can take a long time, some time for the SUV to go down. So, I would say that, the last patient comes to mind at SUV of around 15 before. And then I typically do the PET CT. I give at least 3 to 4 months after the radiation to repeat the PET CT. And it was down to like 6 or 7. So it was still somewhat high. But given the patient's pain has improved, we just are watching the patient. You can consider we will because we are doing whole body MRI periodically anyway. So if it progresses or something, we will know. But I think it depends on what the SUV was before. If the SUV was very high before, then I have seen that it takes a long time for the SUV to come down completely to like 3 or 4.
Thank you, sir. One out of the question which has come to relevant to the subject what we have today. The patient of multiple myeloma doing very well since last 4 years, completed treatment 2 years before. No more treatment was given last 2 years. And now the patient comes to you with a lung plasmacytoma. So how would you go for that?
So if
Only
it's just
a lung plasmacytoma.
yeah, so if it's just a lung plasmacytoma, and what did the patient had before? A solitary plasmacytoma?
Patient had a full-blown multiple myeloma, treated completely with a VRD regimen followed by
Oh,
transplant.
okay.
Uh,
Okay, so full blown. Okay. So I would be worried for this patient because it's an extramedullary plasmacytoma. So assuming that it's not attached to the rib or something like that. So if it's an extramedullary plasmacytoma, like a lung plasmacytoma, that's how the patient has relapsed. I would be aggressive with these patients. We typically in the US would try to take them to CAR T, if possible, given that CAR T is is more effective for high risk myeloma. So even though extramedullary myeloma still has slightly worse outcome, but we have seen definitely good responses overall. So in the US, these kind of patients who present with extramedullary plasmacytoma, we would take them to CAR T, even if their bone marrow is negative, for example.
any alternative to CAR T in such cases?
Uh, I mean, the other good treatment for this would be bispecific. If bispecific is also not available, then I would probably. I mean, if it's depends on how big it is. I mean, if it can fit in a radiation field or something like that. Yeah, sorry, go ahead.
Yeah, it's about 6 into 8 centimeter.
Oh, so quite big. So I would be worried about lung toxicity from radiation, if you have to do radiation. Then I would, I think if the patient is fit, doing one cycle of VD pace is reasonable too. We have seen good responses with those VD pace or DSEP-like regimen in extramedullary myeloma, although it's not very durable. So yes, the patients will respond, but then we need to have a follow-up plan as to what we are going to do afterwards. So, that's where we will sometimes do VD pace and then take the patient to CAR T or do VD pace and then start a bispecific like teclistamab or elranatamab.
Thank you, sir. Another question from Dr. Raghavendra Rajesh Workar. Can you distinguish between a clonal plasma cell versus reactive plasma cells morphologically?
So morphologically, that's a good question. So the only way we can, if it's a reactive plasma cell, then the kappa and lambda ratio will be fairly similar. Whereas if it's clonal plasma cell, it will be extremely skewed, to either kappa or to lambda. So that's how we can tell. And then of course we do flow as well along with that. So the flow also gives us the answer. But we basically look at the percentage skew towards kappa or lambda in the morphology to kind of figure it out.
Anything on morphology or the morphology of plasma cells?
On the morphology, I mean, the pathologists do sometimes will comment if there are like atypical plasma cell with Dutcher bodies but I don't know. I'm not a pathologist, so I can't tell exactly what, if there is any morphological criteria that they use. But yeah, they do sometimes comment that atypical plasma cell, which is suspicious. Again, you cannot never be sure 100%, without the flow.
Perfect. Uh, Thank you, sir.
No problem.
Any discussion want to ask any other question? Because I have finished all the questions from the chat box. Well, sir, in that case, wonderful lecture, fantastic lecture, good learning from you, sir, and a fantastic discussion we had with you. Thank you so much, sir. One question has just come. I'll just finish.
Thanks.
This question is from Dr. Narendra Gemawat. Can we have some screening protocol in the community?
Screening protocol. I
For the-
think, uh, we can, but I don't know yet whether the screening will identify just a lot of people with MGUS or smoldering myeloma, and then it will lead to more resource utilization, more out-of-pocket expenses, and whether it is going to improve survival or not. In Iceland, there is a study ongoing, a randomized trial for screening of MGUS that will give us the answer. I think right now I think it's still premature to know whether screening will really improve overall survival of patients, because when patients are diagnosed with myeloma, as long as they are treated appropriately, they usually have a very good survival these days. And if we screen, we are just going to find a lot of people with MGUS or smoldering myeloma that will lead to more testing, more medicalization overall. So I'm not a big proponent of screening until we get more randomized data from the Iceland study.
Thank you so much, sir. Thanks a
Yeah.
lot.
Mhm.
Well, sir, thank you once again for joining us today and a wonderful discussion we had, sir, with you. Good learning from you. Thanks a lot.
Thank you. Bye.